Povabljeni, da zasedete počasi svoja mesta. Hvala lepa, začenjamo s konferenco. Prvi gost nas že čaka na neposredni povezavi in predlagam, da počasi zasedete svoja mesta. Hvala. Ko imamo zdravje, radi rečemo, da imamo vse. Naše zdravje pa je v veliki meri odvisno prav od moči naše lastne imunske odpornosti. In ko se v tej imunski odpornosti pojavijo razpoke ali se celo sesuje, poiščemo oporo v zdravstvenem sistemu. A tudi ta sistem potrebuje odpornost na izzive, ki so in ki še pridejo. Spoštovane in spoštovani, zdravje smo po epidemiji še bolj postavili v središče pozornosti. Ta nas je opomnila, kako izjemnega pomena je zdravstveni sistem, ki je prožen, ki je odziven in je obenem tudi sposoben predvideti izzive prihodnosti in je hkrati dostopen, kakovosten in osredotočen na posameznika. V zadnjih letih so bili zdravstveni sistemi pod izjemnimi pritiski, obenem pa so se pokazali tudi velike možnosti za inovacije in za prilagajanje. Na tem zagonu velja zgraditi trajnostne mehanizme za podporo preoblikovanju in hkrati tudi prilagajanju zdravstvenih sistemov sedanjim in prihajajočim izzivom. Tudi 12. strateška konferenca Vrednost inovacij se letos osredotoča na zdravstvo odporno na izzive prihodnosti. To je koncept, ki vključuje najširši vpogled v to, kar prihaja, in to je neznano. Zajema pa nove tehnologije in nove modele oskrbe, se dotika upravljanja dobavnih verig in obenem vključuje etični vidik. Le s proaktivnostjo, z inovativnostjo in s pristopom, ki bo prilagodljiv, lahko nastane zdravstveno varstvo, ki se bo sposobno soočati z vedno novimi izzivi in bo obenem zagotavljalo oskrbo, ki bo za paciente, torej za vse nas, najboljša možna. Prijazen pozdrav tako vsem, ki ste se nam na konferenci pridružili v klubu Cankarjevega doma. Lepo je videti, da ste napolnili to krasno dvorano. In dobrodošli vsi, ki nas spremljate tudi v neposrednem prenosu v živo. Dear guests here in Cankarjev dom and all those who are with us online at the strategic conference Value of Innovation this year on the topic of future-proof healthcare. Together with our esteemed panelists, we will look at directions towards resilient and responsive healthcare adapted to the future needs. We need accessible, affordable, qualitative and patient-centered healthcare system. Za uvodni nagovor pa prosim člana uprave Mednarodnega foruma znanstveno-raziskovalnih farmacevtskih družb, današnjega gostitelja, gospoda Domna Groznika. Prosim.
Spoštovane gostje, spoštovani gosti, dobrodošli na tradicionalni strateški konferenci Vrednost inovacij, ki jo Mednarodni forum znanstveno-raziskovalnih farmacevtskih družb letos organizira že 12. leto zapored. Smo v obdobju, ki ga zaznamuje ta hiter napredek tehnologije in stalno razvijajoče se zdravstveno okolje. Hkrati pa živimo v času starajoče se družbe, globalnih, zdravstvenih, ekonomskih in družbenih kriz in zato postaja koncept zdravstva, odpornega na izzive prihodnosti, ne zgolj pomemben, ampak nujen. Zavedamo se, da prihodnost zdravstva ni oddaljeno obzorje, ampak realnost, ki zahteva našo skupno pozornost, predvidevanje in ukrepanje že danes. Vemo, da so izzivi, s katerimi se soočamo v zdravstvu, večplastni. Od naraščajočih stroškov zdravstvenega varstva in starajočega se prebivalstva do vztrajnega bremena kroničnih bolezni in potrebe po dostopni in pravični oskrbi. Toda znotraj teh izzivov se skriva priložnost za preobrazbo in inovacije, priložnost za preoblikovanje samih temeljev, na katerih je zgrajeno zdravstveno varstvo. Zdravstvo, odporno na izzive prihodnosti, ni nepomemben koncept. Predstavlja spremembo paradigme v našem pristopu Do zdravstva in zajema integracijo najsodobnejših tehnologij, vpogledov, ki temeljijo na podatkih in sodelovalnih modelov oskrbe. Gre za vgradnjo odpornosti, prilagodljivosti in trajnosti v strukturo naših zdravstvenih sistemov, s čimer zagotovimo, da lahko prenesejo preizkus časa in nastajajočih izzivov. Potencial zdravstva, odpornega na izzive prihodnosti, je brezmejen. Predstavljajte si svet, v katerem prilagojena medicina, ki jo podpirata genomika in natančna diagnostika, vodi načrte zdravljenja, prilagojene posamezniku. Zamislite si medsebojno povezan ekosistem naprav, ki brezhibno zbirajo in analizirajo zdravstvene podatke v realnem času, s čimer pacientom in ponudnikom zdravstvenih storitev dajejo dragocene vpoglede v proaktivno oskrbo. Predstavljajte si prihodnost, v kateri umetna inteligenca in strojno učenje revolucionirata klinično odločanje, omogočata hitrejše in natančnejše diagnoze ter izboljšujeta rezultate zdravljenja bolnikov. Da pa bi v celoti izkoristili ta potencial, moramo seveda obravnavati tudi etične, regulativne in družbene posledice ter zagotoviti, da bodo koristi zdravstva, odpornega na izzive prihodnosti, dostopne vsem. S tem bomo premostili vrzeli neenakosti v zdravstvenem varstvu. Naša skupna odgovornost je spodbujati okolje, ki podpira inovacije, sodelovanje in izmenjavo znanj, ter ustvarja trdne temelje, na katerih lahko uspeva prihodnost zdravstvenega varstva. Na današnji, že 12. strateški konferenci Vrednost inovacij, bomo imeli priložnost razpravljati o strategijah in o različnih vidikih zdravstva, odpornega na izzive prihodnosti. Izjemni tuji in domači strokovnjaki nam bodo pokazali, kaj je Evropa že naredila na tem področju, ter kaj lahko naredimo pri nas, v Sloveniji. Z združenimi močmi in usklajevanjem naših prizadevanj lahko oblikujemo prihodnost, kjer zdravstvo presega meje, kjer tehnologija krepi sočutje in kjer sta zdravje in dobro počutje vsakega posameznika v središču našega poslanstva in delovanja. Zato še enkrat dobrodošli in hvala vsem, da ste si vzeli čas in se nam pridružili, bodi si v živo, bodi si digitalno. Zahvaljujem se tudi vsem govorcem, ki boste z nami delili neprecenljivo znanje in izkušnje. Verjamem, da bo tudi 12. strateška konferenca Vrednost inovacij doprinesla k povezovanju vseh nas in plodnih diskusijah o prihodnosti slovenskega zdravstvenega sistema. Hvala.
Hvala gospodu Domnu Grozniku za vpogled v prihodnost. Kako daleč je ta prihodnost oziroma kako blizu, je pa seveda odvisno tudi od vsakega posameznika, od vseh nas in od tega, kako dobra ušesa bodo imeli odločevalci, ki odločajo o tej prihodnosti. Pri gradnji odpornejših zdravstvenih sistemov so pa tudi ključnega pomena vlaganja v razvoj in izvajanje novih inovativnih rešitev pri financiranju zdravstvenega varstva, pri organizaciji, pri upravljanju človeških virov in opravljanju storitev. Kako z uvidom vseh teh komponent graditi zdrave in močne temelje za trajnostno zdravstvo, bo predstavil naš prvi današnji gost, spoštovani panelist, zdravstveni direktor na Kopenhagenskem inštitutu za študije prihodnosti, gospod Bogi Eliassen, ki je z nami že preko video povezave, tam nekje nas vidi. Bil je pobudnik prvega projekta populacijskega genoma za sekvenciranje genomov celotne populacije Ferskih otokov. Kot direktor za zdravje Bogi postavlja temelje v tematikah, kot so prihodnost genomike, prihodnost podatkov, digitalnih funkcij in njihove integracije z zdravjem. To temelji na celostni viziji oblikovanja prihodnje personalizirane zdravstvene paradigme kot del ambicioznih projektov in mrež po vsem svetu. Za svoje delo je leta 2019 prejel svetovno nagrado HIMSS Future 50, sprožil je proces Nordic Health 2030 in ima obenem ključno vlogo tako pri globalnem indeksu zdravja Future Proofing Health Index kot pri Movement Health 2030, ki si prizadeva izboljšati zdravje z uporabo nove zdravstvene paradigme. Gradnja pravičnih modelov je v središču njegovega dela, obenem pa je tudi danski predsednik svetovnih kateder za bioetiko. Sebe imenuje posrednik znanja, katerega strokovnost je povezovanje različnih področij znanja. Spoštovani gospod Bogi Eliassen, veseli nas, da bomo skupaj pogledali, katera znanja bodo ključna pri gradnji trajnostnega zdravstva in kakšna je pot do gradnje mostov med področji osebnega in javnega zdravja, zato da bi delovali bolj preventivno, tudi z zmanjšanjem bremen bolezni, ki se jim je mogoče izogniti. Building Sustainable Health and Mr. Bogi Eliassen.
Thank you. Thank you so much, and thank you for inviting me here today to this very impressive event. So, as probably was introduced, Boy Eliassen, Director of Health at the Copenhagen Institute for Future Studies. And we are a 50-year-old think tank that was established by a former Danish finance minister, Knud Christensen, and the first OECD General Secretary. I will not dwell so much on our past, but just saying that we are really working with combining different disciplines and different sectors and also between countries. So coming back to the talk of today, which is really on how do we get health better? How do we get it right? But it's also very important to remember in this discussion that we have came a long way. So probably 150 years ago, the average lifespan was 30 years. Now in many countries we are reaching 80, as well as in Slovenia, but we are getting increased disease burden that we have a hard time dealing with. So this is very much a question about doing the right things right, not just doing the right things or doing the things right, but doing the right things right. And we can also quote Stanislav Lem saying that there are no answers, only choices. To live is to possess a future which will become your present. And this is the essence on how we work. So we are based on megatrends when we work, but the megatrends are something that you also, if you are very focused on it, also can fold and mold into your own direction and can work with. So working with the future in this way is trying to see what can you shape and what do you need to accept, and in that way try to build a better future for all of us in that. Then when it comes to the challenges we see ahead, it's also about a paradigm shift, which I think was said before, but also how do we approach this? So what is the role of health? So if we start saying that health is actually the most important societal pillar to create equality, equity, fairness, sustainable growth and prosperity, it's also to realize economy of well-being, but maybe most of all to reduce avoidable disease burden. And this is the challenge that we have. Likely 30% of the disease burden we see in most countries is avoidable, either by prevention or by earlier and timely intervention when we know these things are coming. For instance, when you have the first chronic disease, how do you avoid the second one? Another part is that we have a high focus on innovation, which is really important, but we are not applying. There is a lot of things we are not applying that we know. And we have estimated in our movement health approach that 80% of health challenges that health systems need to deal with are more or less similar around the world, but still we make it country by country. So how do we apply better? How do we learn better in order to make impact? And I'll just show you this commercial from an old commercial from the US from the 50s. And I'm not showing you this in order for you to think, oh, did we really think that way? I just want you to take this with you back home and say, what are we doing today that to our kids and grandkids in 20 years will be as absurd as it is for you looking at this commercial today? Because we are working with health in an absurd way in many instances. So we also need to remember that knowledge and experience are about the past and decisions are about the future. So while we need to be scientific, we need to be evidence-based, we also need to really understand that the future is not the same as the past. So how do we get that flexibility in? We have ourselves worked a lot in the Nordics with this concept called Nordic Health, and also working much more globally, but always with a preventive approach to health. So how do we reduce the disease burden so we can work better with the resources that we have? So it's not necessarily about first thinking about more money, more financing into health, but repurposing how to work with what we have. And then, of course, some countries need more money, others do not, like the Nordics. But we could also ask ourselves that as we have increased our lifespan from 30 to almost 80 in many countries, we have accepted that the disease burden for each individual also increases. Just the last 30 years on most of the OECD countries, we have gained 10 years of longevity, whereof 5 come with extra disease burden. So try to think if we did the same in traffic, in trains, in cars, in planes. So when we expanded the network of traffic, would we accept that the deaths of the traffic accidents just exploded? No, we would not. So how do we rethink these things? So there is a burning platform that is based on increased disease burden, which I just explained. It's also very focused on end-of-life solutions and has a focus on disease, not on health. And this has a huge impact. So if we take this example on just looking at a chronic disease, we know that we need to be much more to the left in order to have a timely intervention, to have something that gives more dignity and much better lifespan and health during the lifespan for the person. But we only begin to pay when we are very light, very much on the right side. So when it's more expensive, it's more complex, and the impact for an individual and also the value for society is much less. This also comes off that we invest in high-end care for the later stages in disease, but also when we invest with risiko money into health technology, we always push for fast on the market, solve really, really burning platform issues, which is very late in the disease areas. Now, I'm not saying we should not help people with diseases. Of course we need to, but we also need to begin to focus to migrate to the left, so to become earlier, use the technology, use the knowledge, use all the data that we are producing to start earlier in it. So what we are facing is what we normally call wicked problems. So it's socially complex. There is no clear solution. It's very difficult to clearly define it. It does involve changing behaviors, and it's not the responsibility of only one stakeholder. We also know that around 70% of health benefits, it's outside of what we would normally call the clinical health system. One of the focus that we have had the last year is really to look at secondary prevention. There are many definitions, so let me just say that here we are focusing on once you are in a high risk or you have the first chronic disease, how can we help with slowing the progress or stopping that disease progress, but also slowing and stopping the progress towards a secondary and a second and a third or maybe fourth chronic diseases, because the complexity and the burden of disease, but also the economic burden very much also comes off that people have several chronic diseases. So how can we begin to stop the growing disease burden by reducing avoidable disease burden, the ones that we actually can see and we could approach? And
I'm sorry, excuse me, Mr. Bogi, we
of
don't see
course,
your
this
slides.
requires that we... Sorry?
Excuse me, I'm interrupting you because we don't see your slides.
You don't see my slides?
No, I know you have prepared them, so that's why I'm interrupting you, and I'm sorry. But I think they are very interesting slides, so we would really love to see them.
I'm very sorry about that. It said it was sharing. Does it?
Let's try again. Okay, now we
does
see
it
the
work
slides. Now we see the
Okay.
slides, yes, thank you.
Okay, sorry about that. So real-world data, real-world evidence, and evidence-based care for one, and precision public health are concepts that are coming in very fast, and especially with AI that we have seen over the last months exploding, is gonna help us realize these promises. I just need to see. And in the end, this is very much about the best possible quality of life and well-being during the lifespan. So how can we focus on getting that right? It's not about hospitals per se, but how do we get the outcomes in it? In that, there is a very crucial question on saying, what do you want? Is it the best health system so that we can treat anything with any complexity at any given time in a country, or is it actually the healthiest population? So these things are probably in a mix that we need to figure out how much of each, but you probably do not get 100% of both. So that's also a discussion we need to take. We already have a lot of health concepts that have been agreed on globally for a long, long time. So sustainable development goals, One Health, health and all policies, social determinants of health, economy of well-being, which we also can begin to set up in policy approaches, which include several of those things. Also, the 5-5 model I will come in later on is the new biology with genomics, other omics and biomarkers, preventive approaches with avoidable disease burden, the equitable perspectives with universal health coverage and leaving no one behind, and health determinants where we have social, of course, we have One Health and other determinants like commercial and digital. And of course, there are the data and digital and tech with data for better lives, for instance, from the World Bank, with data governance as a core, FAIR principles, and technological, societal, and human readiness as well. This does require, and we also have a high push from new players, but also new payers into health. So where do we work with health? How can we work cross border? So the big ICT companies, they are investing heavily into these areas and will also have an impact whether we like it or not. So our responsibility is to work with the ones who can provide value to societies in a way that is both sustainable and ethically sound. And we also come into what I call the $100 tipping point. Probably a genome sequence is $100 if you do it in bulk already now in some places, but it also will be so. But there are also several companies working on assembling all the relevant data for a person for around $100. So the thought experiment here is, what is it you can do when you get these data and you have AI and you can combine it in different ways, and the cost is $200 compared to a CT scan, which is much more expensive. So this will open totally new ways of working with and thinking health. So what are the focuses that we see? So it's a well-being over the lifespan, but it's also maybe a shift from a lifespan to a health span. So how healthy can you keep people in this part? And it is, of course, much more patient-centered, and value-based care is beginning to focus much more on outcome and not just the supply chain in it. Personalized is in there with precision, and a stronger focus on prevention, where the secondary prevention probably is the point where we can start much more efficient today. In the Nordics, we ended up with a conclusion with some 35 major stakeholders in the Nordic that we should aim at 2030 by saying half of the health budget should go towards prevention. It's 5-5 because the Nordic countries use 10% of GDP on health. So meaning that trying to push that half of it would go towards primary, secondary, and third-tier prevention by 2030 as a goal. Then you could say, is that realistic? I don't know. Maybe it's pushing that way, but even if we only reach 10 or 15, it's much, much better than today. Another principle that we pushed very hard in the Nordic was what we called 80-20, meaning that in a given point in a society, you have more or less 20% that really need intensive care and 80% that you, with a little bit of health, can keep healthier much longer if we do that. So how can we focus on both keeping these 80% healthier longer, so we can use much more energy and better energy on the 20% that really need it, because we are not helping them well enough. And the 10-90 principle is also to push the fact that the focus, especially of companies, is on the 10% richest in the world, leaving the 90% outside of that. So how can we look at the 90% of the world and really make impact for them as well, also from a business point of view. So the question here is, how do we create societal value by helping individual systems as well? Because if health is an investment, it's also something you build societal value with. So with a healthier population, you also get more dynamic into the society. One of the things, and sorry, I'm getting a bit complex here. I don't know if you can see the screen, but one of the things that we also did in the Nordic program here is to say, okay, what happens if the person is their own biorepository or biobank and digital repository, just looking at data that's already accessible out there today. So what if you as a person, you could have access, of course you need AI to this, and just noting that this was made in 19, so AI was not that advanced at that point. But if you give a person access to their genomics, to their different societal factors and environmental, micro and macro environmental factors that can impact them and their personal behavior, so you actually can help people, give them a tool to take more care of themselves. So those who can, the 80%, and that of course requires both transparency and traceability, accountability, the consent. There are a lot of ethical things we need to consider. But if we want people to have a more sustainable behavior for our health, we also need to help them with tools, not just help the system. But working with that would also require a sustainable health model where you connect the aggregated data and individual data, so you enrich both ways. Because our systems today are very much based on very static data points and are not really enriched in the way that we actually can work with data today. So a sustainable health model would probably need that you work the personalized health and the public health in a combined way, which we actually have tools to do. Just a very few concepts. The first one, Tverspo, I know it's a difficult name, is a hospital in Denmark which has used a lot of predictive on what they know in the data to see how do you then manage the staff at hospitals, looking at if you have football in the city, is it good or bad weather, is it winter or summer, what was the push on the hospital the last 2-3 weeks, what was the push on the GPs, and with that you can actually predict very well what you need of staff for the next week on that hospital, and this is based on AI models. In phase 5, we are working quite hard with a new way of doing decentralized clinical trials with persons in the center, which probably is the future, and so you let people be at home as much as possible. And Data for Better Lives is also very much on data governance in order to use data in order to get better lives for everybody in the world. Often we are complaining to the political responsibility that that's not high enough, and we always see these cycles of 4 or 5 years, depending on you are. But I will claim that we actually need to push much more on individual responsibility, public sector responsibility, corporate responsibility, and civil society responsibility, because that's where the longevity is. So yes, we need to demand for the political system, but we also need to take much more responsibility ourselves in where we are. So it all comes back to data governance. We are moving from an analog model to a digital model. We are not prepared for that. Our legal frames are not prepared for that. So consent, transparency, traceability, and accountability are key. So these are ways we need to push and enable the use of data and digital functions. It doesn't work to try to fit that with analog thinking on frames. What we did with human rights, and we spent 200 years on this, was to protect the individual from states, from organizations, and from criminals. And it's more or less the same we need to get right in it. So we don't have to overcomplicate it. I know it's not easy, but we need to simplify without making this simplistic. And one of those things is the health literacy. So how do we get the population, the decision makers, but also the healthcare professionals really to understand and get a high health literacy that is digital and we can use to work going forward. And that's very much about leadership and getting capacity building into the system in a totally different way. So going back to the Nordic health, where we are really focusing on a sustainable approach that we started in 19, we built the Nordic on 5 values, 5 Nordic values: trust, trust, creativity and innovation, openness, individual responsibility with solidarity, and cultivation. So how do you give people capacity to work with knowledge in the system? I'm not saying that these should be the ones that we use everywhere. I'm just saying that it's very important to build on some pillars when we go forward. In the movement health, which was also mentioned before, we started with 4 focus areas on improving access to quality of care across the lifespan, and the new biology with advancements in science and biotechnology, really on the data and digital solutions, which is our main focus today, and of course to build it sustainable in the country. And in the end, the sustainability is key. But sustainability is a lot of things. So what we are trying to do is to create and build with partners. So how do we do this sustainability piece? Because it's about carbon footprint, it's about waste, it's about better use of resources, it's creating value, it's decreasing the disease burden with health span. So we actually need less input into the health system, and to decrease the avoidable disease burden. And of course, you have to see health as an investment. The huge challenge we have here is that we both need much more hyper-specialization at the same time as we need holistic system thinking. And this is very hard. We don't really have the leaders today who can do this, not on any level. So we also need to develop those parts. And as the famous Honda said, vision without action is a daydream, action without vision is a nightmare. And because we are missing some of these things, we often end up in challenges which are nightmare-like. And this also comes back to that, oh, now my slides got their own life. I'm very sorry, I'm going a little bit back to finish off my talk. And this also, here we go, sorry. This also comes back to that we need readiness in the system to be able to work with these parts. Technological readiness, societal readiness, and behavioral readiness needs to be in place for us to be able to go forward. And often we underestimate that these actually need to be synchronized. And here, 2 main ways of thinking. So technical change is when you do a reductionistic approach, when you know what you do, you have an Excel sheet, you do your Gantt chart, and then you just work. It's like building a house. Adaptive change is what we are standing over for, that we know we need to change, but we also know that we don't really know what to do before we are in the process. And everybody wants to do that. But what we do is that when we give funding, we set the frames for technical change to work with adaptive change, and it fails. And this is why we see so many failures in these kinds of projects and work. And we call that work avoidance because everybody is stressed, but nobody does anything that is of value in it. So we are actually in a beyond repair situation. So where we need to rethink for systemic change in systems and behavior, but we should not reinvent the wheel all the time. There are so many things we can use. So the end of here is that health needs to move from cost to investment. So my really question is not if we can afford to do the future costs of healthcare services, but if we can afford not to invest in keeping people as healthy as possible. And the most important thing for me is always that if we want to change things, if we want a new paradigm, we actually need to ask the questions before we seek the answers. Thank you so much.
And that's why this is the time for the questions. Torej, prvo vprašanja, mislim, da prevoda ne sliši Bogi, a ne? Če se ne motim. Do you hear our translation from Slovenian to English language, Bogi?
No, I do not.
Okay, so we'll ask for the questions in English. Not everyone at one time, just one question at one time, okay? So we see the first hand for the first question. The lights turned on. Yes, we have the first question. We just need the mic. Thank you.
Thank you very much, Petra Dosinovic-Bonča. I have a question. You talked about the role of prevention and the 5-5 rule. Currently, if we look at the expenditures for prevention, we have the data based on national health accounts, and the data actually indicates that we, in Europe, dedicate about 3% of overall expenditures to prevention. But this does not include secondary prevention and tertiary prevention. So I was wondering, what are your estimates? Where are we in Europe relative to the goal that you talked about?
Yeah, it's a little bit of a difficult question in it because nobody has really looked at the data on that part. But if we look at primary care as such, that average in Europe, I think, is between 25 and 30% in that part. And of course, everything in primary care is not prevention. But let me try to be a little bit more clear on, for instance, a case to look at. So when you have if we take Denmark, where you have very good data, so you can actually see when a person has a chronic disease, the pathway to the next chronic disease and the third chronic disease. So these are things, when you look at the big data, you can actually see patterns. I'm not saying it happens for everybody, but it happens for most of them. So the thing that we want to focus on in our first step in secondary prevention is to say, okay, if we have this knowledge, can we then go in? So this would be more timely and more precise to help these patients to not progress more. Coming back to your estimation of the data, which was a very clear question, my estimation when we go in to work with it in that way would probably be 10 or 15% if we go to work with it in that way. But what is missing, and this is the whole point of changing the paradigm, is that we are not thinking prevention in the care as we could in order to reduce the avoidable disease burden, so the 30% that we have in most countries.
Thank you very much. Do we have another question for this very interesting first panelist? I think we heard a lot of interesting things today. Especially we'll take home the thought that health is an investment for all of us. So if there are not any questions here at this moment, another question, yes, please.
Thank you for very fruitful and interesting presentation. My question, I'm quite fascinated that you merge all those activities in the Scandic area. So we know that traditionally those countries are cooperating daily, but what were the reasons that you merge all your activities and you have common vision? Do you think something similar should be also applicable in Slovenia, which is a small country, but of course we are having commercial activities with our neighbors, Italy, Austria, Germany, and similar. So would it be recommendable that we, for example, do some similar effort in our environment? Thank you.
Yes, thank you so much for the question. I think it's a very important one to stress. So of course there has for decades been established collaboration between the Nordic countries, but it's and the Nordics are also fairly active in the European or the EU collaboration, and these are two different how can I say dynamics. The Nordic is more on the culture and social part, so more softer than the European part on that way. But there is I don't know if it's a commonality between the cultures, because there are also big differences, but it comes more back to the point I mentioned with that probably 80% of health challenges that we have around the world are very similar. So there's a huge benefit in collaboration, learning and doing things here. The other part, so there are two other parts which really triggered this work in 19. So one thing is that we are moving from analog societies to digital societies. And if we want to keep the welfare system as we have, it actually needs to be rethought through. So because The solidarity in an analog system is geographical. In a digital system, it's both geographical and not geographical, because you would begin to work, for instance, with rare diseases around the world and these kinds of things. And then it also comes in that with the huge investment in personalized health via genomics and big data, the populations are too small, and this would also cover for Slovenia. So working with 2 or 5 or 10 million people is simply too little in order to get the real power in working with the new technology in it. There are some things you can do much better, much deeper, and connect much better. But there are other things where you really need to be connected into a world in order to make the impact and the learnings of working with both the new biology, so genomics and others, and with the data. So, for instance, lung cancer already has at least 20 subdiseases with different biological traits in it, and this will happen with most diseases where we become much more granular in it. So that was one of the other reason in it.
Thank you very much. Mr. Eliasson, maybe a short question?
Yes.
If not, I would love to see you, Mr. Eliasson, next year here in Slovenia, because I'm sure when the lights go down, we have much more questions for you. So you're welcome next year, okay?
Thank you so much. Thank you so much. And enjoy the day. And sorry about the slides.
No, great.
I can share,
we would love to see
the
first. Can you show us one of the first slides about the? You were talking about an advert 20 years ago.
Yes.
We were all wondering what that was.
Yeah. Let me see if I can get back into that. Can I do that? So I need to.
Bogi has lots of monitors there, I think. That's why he needs to find the right slide.
Let me just do it in the brutal way, and then we do it. Are we getting back? So you can ask me a question while I'm working on a non-very digital savvy way.
No, I was just wondering if we can see you live next year. That's the main question. Yes.
So here we go. Here.
Oh, yeah, we were. I think we were close to that one.
So here is the question. When you get the questions in 20 years from your kids or your grandkids, that will make you really embarrassed. So what are you doing today, which will make you feel like this?
Thank you again.
Thank you so much.
Hope to see you next year, and have
a
great
so
day.
Too.
Yes.
Thank you.
Goodbye. Bye-bye.
Goodbye.
Mr. Bogi Eliasson will be with us. Will stay with us through the 2 next panelists. Nadaljevati moram v slovenščini, mislim da. Torej, zdravstvena industrija se sooča z mnogimi izzivi. Danes smo nekatere že slišali, od naraščajočih stroškov in starajočega se prebivalstva do novih bolezni in globalnih zdravstvenih kriz, in z izgradnjo sistema zdravstvenega varstva, ki je, večkrat ponavljamo, prilagodljiv, inovativen, trajnosten, bi seveda lahko zagotovili, da bolniki, da mi vsi prejmemo najboljšo možno oskrbo. Zato govorimo o zdravstvenem varstvu, da smo vsi varni v njem. Poleg tehnoloških in logističnih pomislekov pa mora zdravstvo, odporno na izzive prihodnosti, obravnavati tudi etična vprašanja. Ker nove tehnologije, tudi te smo danes že omenili, kot na primer genetsko testiranje, postajajo vse bolj dostopne, morajo ponudniki zdravstvenih storitev upoštevati etične posledice uporabe teh tehnologij, vključno z vprašanji zasebnosti, informirane privolitve in socialne pravičnosti. Naš naslednji govornik bo zato Ricardo Leite, ustanovitelj in predsednik globalne platforme sedanjih in nekdanjih članov parlamentov, kongresov in senatov, ki je prisotna v več kot 95 državah in je obenem tudi uradni partner Svetovne zdravstvene organizacije. Je podpredsednik parlamentarne mreže Svetovne banke IMF in globalni ambasador partnerstva G20 za zdravje in razvoj. Predseduje Centru za globalno zdravje na Šoli za informacijsko upravljanje in znanost o podatkih in je gostujoči predavatelj na Medicinski fakulteti Nova. Dolga leta je bil zagovornik in javni govornik ter avtor številnih zadev glede zdravstvene politike, javnega in globalnega zdravja, globalnega in lokalnega upravljanja ter digitalne preobrazbe. Je obenem zdravnik, specializiran za nalezljive bolezni, od leta 2011 je bil tudi poslanec portugalskega nacionalnega parlamenta, no funkcijo poslanca pa je prav v teh dneh zaključil, saj je sprejel službo glavnega izvršnega direktorja IDAIR, The International Digital Health and Artificial Intelligence Research Collaborative v Ženevi in zelo smo veseli, da je z nami na letošnji konferenci, nam bo odstrl glavne izzive na poti k pravičnosti in trajnosti. Moving towards equity and sustainability. Ricardo Leite.
Well, thank you so much for the kind introduction. It's a great pleasure to be here among all of you. It's my first time in Slovenia, certainly not the last, but first times are always special. And I'm happy to be spending this first time with all of you. And I have this tremendous challenge of speaking to this dark room a little bit before lunch. So I'll try to keep you all awake. To speak about the challenges we have ahead of us, we've heard many things that I agree with. I'll just try to complement what we heard with some concrete examples and also sharing a bit where I come from in Portugal. And we created a national health service following our revolution in 1974, which aimed, built from our constitution, it aimed to become a universal health platform, very much inspired by the British NHS. And throughout the years after the revolution, the mark of the SNS, which is our NHS, which was 1979, you can see life expectancy continued to rise. We saw that health outcomes generically got better. You can see that Portugal was presenting infant mortality rates that were actually above average in Europe and almost at sub-Saharan levels before we had a national health service. And today Portugal is a reference when it comes to infant mortality rates. So these are some examples of how we were able to achieve with universal health coverage interesting results, and doing that spending much less than average OECD countries. I'm going to be sharing some data from OECD. Eric, I'm sure, who will be speaking afterwards, will follow up. But this shows that actually we are spending significantly less, especially when we look at public expenditure, than OECD countries. So when we look at this study from 2014, it's almost 10 years old, but at the time, it's particularly relevant to look at it because it was at the end of the financial bailout that Portugal went through when IMF had to bail out our country following the 2008 financial crash. And Portugal's health system was actually, when crossing health outcomes with expenditure, Portugal was among the top 15 health systems in the world. So those are all positive outcomes. I would argue that we invested tremendously on the quality of our healthcare professional training, and that was the main cause of success, along with, especially during the first years of our national health system, an integrated health system. But moving forward, we have many challenges, as was said by our kind presenter. And the truth is we have a challenging demography. When you see here in Portugal, today, the active population is around 6.6 million people, with 2.3 million at the age of 65 or older. But in 2080, if everything continues as it is, we'll have around 4.2 million people in an active age and around 3 million people over the age of 65. Well, in Portugal, as in many countries, we have a pay-as-you-go pension system. So the active population of today pays the pensions of today. There's this idea that when we pay to Social Security, that they are saving the money somewhere so we can get it back when we get into retirement. That is not the case. It is the taxes that are paid today that are paying those pensions tomorrow. This creates a tremendous challenge, along with all of the health challenges that we've started to hear. And Slovenia is a bit better when it comes to an aging population, but you will be facing similar challenges moving forward. But I can see that you're having more babies than we are, which is a good sign. We see that with the rise, the older your population, the bigger the challenges when it comes to non-communicable diseases. And you see dementia. Portugal is going to be most probably the third biggest country when it comes to dementia prevalence among OECD countries. Slovenia, fortunately, is better, but you can see the number is also on a rise as most countries. When you see elderly care, both our countries are below OECD average. When it comes to capability of receiving long-term care, Portugal, sadly, is at the bottom of that list. So not only are we having the oldest population, one of the oldest populations in the world, but at the same time, we are very illy prepared to have an institutional response if needed. And we see, for example, the main causes of mortality. It's no surprise that cardiovascular disease is, of course, the main cause of disease around the world, and then cancers and respiratory diseases playing a very, very important part. And we see that among these top killers, it's quite shocking that we also see metabolic diseases on the rise, the challenges of obesity, the challenges of diabetes. We have 10 million population in Portugal. It is estimated that we have 13% prevalence, 1.3 million out of 10 million with diabetes. That alone is a ticking time bomb that will explode in our hands. And diabetes, from a public health perspective, is more than a disease. It's a reflection of social condition. It is a direct consequence of poverty and inequities and needs to be addressed. And also when we talk about mental health, which are on the rise, particularly after the pandemic, we have seen that 1 in every 5 children, teenagers in Portugal, have some form of mental health challenge, and we're seeing these trends around the world. And then we have this other problem, or challenge, if you will, which is the need for a health workforce that can respond to the needs. And I'm showing you a table, which was a projection made in 2014 of how many doctors, family doctors we would have in Portugal, and the number of patients or citizens that would not have access to a family doctor. And you can see here that by 2023, it was projected that 500,000 Portuguese citizens would not have access to a family doctor. The thing is, the richer countries in the world are importing doctors, nurses, and other healthcare professionals from our country. You are feeling the pain too. And instead of 500,000, we have almost 2 million Portuguese citizens without access to a family doctor. The German government is paying for German courses in German language to third-year medical students in Portugal, so that when they finish their course, they are offered a job immediately, earning 5 times more than they would earn in Portugal. This is one of the biggest challenges that we will be facing in a hyper-specialized world of the future, as we heard before. Another challenge is the way we distribute our healthcare workers. We normally look at data in terms of national distribution of healthcare workers, but most of those healthcare workers are in the big urban centers. Distribution across the country regionally, as you can see here in Portugal, and in Slovenia you also see a similar phenomenon, is that beyond Lisbon and Porto and Coimbra, which is our 3rd biggest city, most of the region has below average coverage. But the most significant one is the distribution within the health system. And this, in the blue bar, the dark blue bar, you can see represents hospitals, and the gray bar represents primary care. So we're always saying primary care is the base of our health system. Primary care is what we want to invest more, but actually, when it comes to looking at hard data, 2/3 of our healthcare workers are working in hospitals, which should be the last place where patients go. The hyper-specialization of hospitals have become the entry point for our health systems, which is a reflection of a broken health system, which is not a health system. We have built across the so-called West disease systems, systems that lead to more and more disease. And when it comes to nurses then, because of the challenges that I mentioned, we are below OECD average, although we actually train more than we actually needed. Just between 2015 and 2022, Portugal trained 13,000 nurses, and we exported 15,000 nurses. Okay? This is an issue we need to talk about here in the European Union. We have to talk about in the global health space. So I've shared with you some of the challenges. Now let's look into the future. And there are many projections that show that there's going to be a rise of costs, inevitably, with the technologies, personalized medicine, everything we heard before. All of this is amazing and fascinating. Somebody has to pay the price. And we see it as an investment. But what this study interestingly shows is that actually there are two ways to take this challenge ahead. Either you can continue business as usual, and in the case of Portugal, we'll go up from 6% GDP to over 14% GDP in 2060, or we can actually perform the reforms that are needed and keep expenditure below 10%, which means hopefully making it sustainable. In other words, if we do nothing, the system will break, it will not be sustainable, and only people who are rich, or at least have some resources, will be able to have access to the kind of care they need, while others, well, they'll be left on waiting lists. That's the Americanization of health system that is happening in Europe, which is exactly the opposite that our social values had always defended. We were proud, but the way we have built our health systems is a trap that we need to get away from. And so I believe the basis of what I'm going to say next is based on the European social model, which believes in universal coverage, equity and access, the offering of high quality of healthcare, and solidarity in funding. But to fix health systems, to make sure that they are sustainable, resilient, they transform themselves from these disease systems to becoming systems for well-being, systems promoting health, we actually need to go back a few centuries, back to the history, back to Hippocrates, even before him, and understand what was healthcare all about. And the goals of medicine were very easy back then. Promote health, preserve health, restore health when compromised, and minimize suffering and malaise. Then the Industrial Revolution happened in the 19th century, which completely transformed the world, in many ways for the better. We continue to make cars the way we did more than 100 years ago with Henry Ford. This thing is, business schools in the last century, particularly in the 1970s and 1980s, started looking at Japanese car makers and say, these guys are very efficient. Why don't we import these management models into healthcare and transform healthcare to become more efficient too? And that led to what I like to call the industrialization of healthcare, in which we created this dogma that the more surgeries we perform, the more hospital visits that happen, the more treatments we provide, the more tests we do, the healthier the population. But in the middle of all of that, somebody forgot to measure results. And what has happened? Well, we saw a rising of healthcare costs and a rising of burden of disease, risks of insustainability, which lead to compromising actually putting at risk our universal health coverage, which leads to worse health, particularly for those that are most vulnerable, for those that are more poor, and this leads to a rise of inequities. So the gap between the rich and the poor actually rises, instead of health systems helping to close the gap, as we always saw health as the main driver for development, as the main social ladder in societies. And that's why Michael Porter at Harvard Business School with his team came up with the idea of value-based healthcare, looking at saying that in healthcare, the days of business as usual are over due to the social inequities, raise of costs with technology, demographic pressure, the need for qualified healthcare workers, chronic diseases, and the raise of the burden of disease. So they took away my my animations. So the second carrot was supposed to appear only after, but I'll get you through it. So the first carrot that you can see at the left side of your screen was the carrot of incentives. You can call it financial incentives, you can call it any other form of incentive that you may use for the people managing a hospital. And today, a hospital in this industrialized view is a factory where we actually pay for more surgeries, more hospital visits, more treatments, more emergency room visits. And the more you treat, the more money you get. And so we're actually creating incentives for more disease. And what I would argue, and that's the idea behind value-based healthcare, is getting that carrot from the left side to the right side to where the patient is, looking at health outcomes, PROMs, PREMs, patient-reported experience measurements, and outcome measurements. And I'm using cartoons because I speak with politicians. It normally gets the message better. I'm not underestimating your intelligence. But we can see here a very concrete example from my country where measuring results actually works. So this is primary healthcare data. And in Portugal, we have a real-world scenario where we have more or less half of our primary health clinics, doctors and nurses get a salary no matter what they do. And the other half, we have contracts based on health outcomes. So they actually have incentives. And those are what we call family health units. And that's what you can see here, USF-A and USF-B. In USF-A, we measure results but don't pay incentives to see if they can work in this model. If they are successful, then they move to B, in which they actually get a financial incentive. This UCSP, the one on the left side, there is no financial incentive and no measurement. So when a study was conducted, we saw that only 35%, 37% of the hypertensive and diabetic patients were controlled in the setting where there is no measurement and no financial incentives. In the middle, USF-A, we measured results with no financial incentives. It went up to 52%, 59%. And when we put a financial incentive on top of that, it went up to 64, almost 70%. And what this shows is that just measuring gets better results. It almost doubles your results. And if you put a financial incentive, you actually get even better results for your patients. So when people tell me that measurements don't work, and that financial incentives don't work, and looking at outcomes don't work, I show them this. Another example many of you may know from ISHOM is looking at prostate cancer surgery. And mortality in prostate cancer surgery is very low. 95% of patients survive. But then a Martini clinic in Hamburg, in Germany, decided to look at outcomes that the patient cared about, like sexual dysfunction, like urinary incontinence. And they said, why don't we start measuring these outcomes? And what they did was they started measuring, and they started changing their surgical interventions and performance. And when we see the average outcomes in Germany and Sweden, when it comes to 1 year incontinence, 43, 50%. At Martini Clinic, it's only 6.5% 1 year after surgery. Or when we look at 1 year severe erectile dysfunction, 75, 80% of cases in Germany and Sweden, which are very good health systems, 34% at the Martini Clinic. So let's pretend we all have prostates for a second. And if we did and we needed surgery, where would we want to be treated? In a random hospital in Sweden or Germany, or at the Martini Clinic? Mortality is the same, but I'm sure that all of you would want to go to Martini Clinic because we all want to pee when we want. We all want to have to continue to have sex because living is more than surviving. It's quality of life, but you have to listen to patients. So I actually disagree with the idea of patient at the center of the system. The patient has to be everywhere, from the board meeting, from the decision process, from the negotiation, from the definition of what outcomes mean. At the end of the day, we are only here to serve the citizens and the patients. Everything else has to work towards them. We don't need just this idea of a whole bunch of experts around the patient. We need the patient to be part of defining what success means for them, because what means success for them means success for everyone. And so this leads us then to an analysis of health outcomes versus cost. And this graph, you can see here that the purple line represents the evolution of outcomes versus costs. So on the axis, on the vertical axis, you can see outcomes. On the horizontal, you can see costs. And of course, in poorer countries, if you put a little bit more money, outcomes go up exponentially. But it gets to a point more or less at Singapore, one of the most efficient systems in the world, where it doesn't continue to go up. No matter how much money you put, it's a plateau. It's interesting. And even at the US, it drops a bit. With value-based healthcare, I think we'll get the green. It'll go up. With the same money, we'll have better outcomes, but it'll plateau too. And there's a reason for this. And this is my critical take on value-based healthcare, the way it's been designed. It's because the fact that we continue to focus on disease, I only have 1 minute, but I'm going to ask just for a bit of tolerance. The fact that we focus too much on disease leads us to the fact that we are seeing a rise of that burden, because we are not intervening at the societal level. And so the question is, going back, how do we get to that red line where we continuously get better health outcomes at the same cost? And so to address this, we've heard it, we need to look at what actually impacts an individual's health. Be it the clinical factors, which is 10% of what impacts our health. That's what doctors and nurses see when they have the patient in front of them. The genomic factors or biological factors, that's 30%. We see personalized medicine is going to be addressing this, but we're still a bit away from this. And 60% are exogenous factors, our behaviors, where we live, the environment in which we work with. And that represents 60% of our health. So actually looking at determinants of health, at housing, working conditions, all those factors, we know this is critical, but that is not addressed by our health system. So the carrot that value-based healthcare system says it has to be at the patient, I would say it has to be in the community. And we can use community-based outcome measurements, I like to call them C-bombs, where you can actually monitor, measure outcomes in your community, and then you can create incentives. So it doesn't matter just to control your diabetic patients and your hypertensive patients. You actually need to avoid new cases of diabetes and hypertension. You need to lower the burden of disease, prevent everything that is preventable, cure every disease that is curable. And to do this, we need a technological platform. And I had a lot of things I wanted to get into. Fortunately, Eric is going to follow me, and he'll be able to get into further detail. I'll jump a few slides just to say that when we look at the 60, 30, 10% ratios, this represents a lot of data. And so to deal with all of those data, truly we have an opportunity here, which is evolving our health systems that can focus on becoming advanced clinical support systems. And for that, of course, the rise of cognitive computing and artificial intelligence is an important part of that. And we've seen Watson from IBM or DeepMind from Google and so many other technologies that are rising. At the end of the day, they do three main things. Understand natural language and human speech. They generate and evaluate hypotheses for better outcomes, and adapt and learn as we use them. The idea is not to substitute humans. It's to make sure that we get the computer screens out of the way in the office. We can look at patients, become more humane, and leave the administrative work and the hypothesis generating to the machines, so we can task shift the boring stuff and get back to what matters as healthcare professionals, focusing on the interests of the patients, using knowledge and data as drivers to fuel these engines of support decision-making. I had some examples of how this works. I'll jump this. But at the end, we have the rise of this digital healthcare triangle, which is focusing on sustainable health, so risk reduction and wellness, changing these disease systems to focusing on well-being and quality of health, digital medicine, looking at an infocosmos of healthcare, and molecular medicine, as we've heard, focusing on precision diagnostic and precision treatment. And of course, the 5G revolution that is working in telecommunications is transforming the way we use the internet. So until now, we used to go online. Now we are part of the internet. This is a huge transformation that will influence everything we do. And so data is going to be critical as we move forward, and we need to understand the power of data, and we need to educate the people to understand that giving blood and giving data can both save lives, but we're still not there. And so understanding that data is the electricity of the 21st century, without which none of the reforms we're talking about will actually work, we need to create incentives that get people to want to participate. Why not even think about models in which states are going to make so much money if they create health data agencies, they can give away dividends through IRS to their citizens? Why don't we create financial incentives for citizens to participate in this data sharing, data solidarity approach. And that's why I actually took on this role as the new CEO of IDARE, the International Digital Health and Artificial Intelligence Research Collaborative, based in Geneva, as a neutral platform working with WHO and hopefully being able to work with Slovenia moving forward so that we can make sure that we guarantee better research, but also access of responsible digital health and AI solutions that can help this transformation where outcomes over costs leads to better quality of life and well-being for all citizens, improving health, reducing costs, and improving care across the board. Thank you very much.
Questions? Do we have any questions? Maybe about C-bombs at this moment or about carrots? Tanya.
Yeah, hello, my name is Tanya Španić. I'm a patient representative, president of Europa Dona. I'm really happy that you addressed patient-centric healthcare and how this is taken into account, because I strongly agree with you that patients should not be in the center, but it's all around. And when we talk about personalization, especially, well, oncology is my field, so I can talk mostly about it. We really need to start treating the patient, not the tumor, biomarker, and everything that we can get with genomics and all other tests. My question for you would be, where do you see maybe this going through prevention and behavioral changes to the treatment? How can countries like Portugal and Slovenia can improve and maybe move closer to Sweden or Denmark with their outcomes?
Well, I don't know if anyone really has fixed the problem when it comes to measuring outcomes, to be honest. And I've heard many times that, no, first we need to consensualize what are good data sets, so then we can actually start moving forward. And I've been hearing this conversation for 15 years now. So I would say, why don't we start with the data we have? And why don't we start actually organizing ourselves? And I can share you an example from my country. During the financial crisis, we had this huge problem where every hospital has their own electronic health record, everything works in a bit of silo approach. So what did we decide to do? The Ministry of Health decided to create a health data platform, which is a cloud-based system, and told every hospital clinic working in the country saying, if you want to continue to operate in our country, you can use whatever system you want, as long as you send the following data sets from your health system to the cloud, which is then organized. I continue to see that as a very interesting solution. I think there's other technologies that we can use to give it more power to the patient, like blockchain or others. And of course, the data that exists is very much focused on old school, mortality-based indicators. But as we move forward, creating that basic infrastructure and creating what I believe is a necessity, which is a health data agency, can help actually galvanize that kind of transformation that you need. Many times people say, if you only had 1 year in the Ministry of Health, what would you do? And my answer is, after long thought, I always say I would do two things. And that's emergency and infrastructural response. On the emergency side, I'd find ways to use the whole of the health system, public-private, together to respond to the immediate needs in terms of family doctors and waiting lists. But on the infrastructural side, if I only had 1 year, I wouldn't have time to fix the whole governance structure of health system, but I would have time to build a health data agency focusing on health outcomes, focusing on wellness and quality of life. Because that is the basis on which then we can build new governance, new financial models. And if that health data agency has one mission, one North Star, which is making quality of life better for each citizen, focusing on well-being, then that can be the starting point to go from a disease-driven system towards a system that actually promotes the well-being of all citizens. I hope that helps. And maybe we can do this more at a European level, not just national.
Thank you very much. We have another question at the back.
I was hoping you could expand a little bit on the challenge related to workforce shortages. So what are the discussions that are happening in that regard so you don't limit the free movement of workers in the EU?
Thank you, Tjasa.
Well, that's a very hard question, and nobody has an answer. But what I can tell you is the following. I'm against ending the free movement of people. It's that I do not believe will fix the problem. We see that when you try to limit people's movements, they find a way to get out. We've seen that over history. It's not the way to go. So it's creating incentives that actually try to understand what is important to the citizens. I have seen colleagues of mine leave public health services to go into the private sector, earning exactly the same salary. And I asked them, why would you do such a thing? And they tell me, well, I'm more respected, my work is valued, I get to choose my schedule, I can be closer with my kids, I can pick them up at school, I have my own office, basic things. It's a question of respecting the work. And what we see normally is governments taking a top-down approach. Okay, let's create these incentives. And then you see they don't work. So we have to turn the table around and ask the people we are training, what is important for you to come on board? So that's one angle. So on the policy governance side, I would say. On the other angle is the power of digital. In many countries, my own included, we are seeing pharmacists, nurses, doctors, doing a whole bunch of work which is not theirs to do, administrative work, wasting time of highly valuable resources doing things that they shouldn't be doing. So that's where I believe the power of the digital transformation can actually help us. And we are part of the European Union. There's millions of euros available for digital transformation. I am seeing that money being spent on computers, on updating infrastructure. Of course, it's important. But we're wasting an opportunity because we are transforming what is analogic, what we already do in the analogic world, into the digital, but keeping the process the same. We should be using the digital revolution to actually take us to the next level so that we can task shift to machines the work we don't want our healthcare professionals to do, so we actually don't need so many healthcare workers to take care of the patients at the end of the day. And so I would say it's working in these two fronts, on governance, policy, and on the other hand, using the power of technology, that we will be able to address the challenge in the future. But at the end of the day, I have to say this. The most efficient hospitals are the ones that have no patients, right? And there's this episode, do you know this TV series called Yes, Minister? Yeah, so it's a British sitcom. And so the Minister of Health was told that the most efficient hospital in London just won an award of the most hygienic hospital in London. And he said, oh, I have to see this. As a politician, of course, he wanted to take the media with him, so he went to the hospital. When he got there, he visited the hospital, and when he was in the operating room, he turned to the president of the board of the hospital and said, where are the patients? I haven't seen patients yet. And she says, oh, we haven't opened to the patients yet. And he said, why are you working? Oh, we have 500 people that we have on salary. We can't close. And then he said, well, I'm closing it until you open to patients. And the union person came, then we're going on strike. And he said, then go on strike. It just goes on and on. But at the end of the day, what I'm saying is, if you're able to lower the burden of disease, the less patients you need using hospitals, the more resources you'll make free to treat those that need it, the more efficient we will be. The problem is, since we have failed redundantly and seen so many people sick that shouldn't be sick with multimorbidities, having to use our health systems across the board, well, then there are not enough resources to go around and not enough healthcare workers also to respond. So I'd say those are the three pillars to try to respond to your difficult question.
Thank you. Do we have another question? Maybe the last one right now. Do we have one? Yes, we have one question.
Yeah, I'm sorry, but I'm very skeptical about your solutions. You have done quite a good diagnostic presentation, but I'm afraid that digitalization is far from the optimal solution. Okay, it can help to the healthcare system, But to see the technology as the treatment of the healthcare systems, I believe it's quite wrong. I mean, it's impossible to go into the details, but I'm afraid that this is not a solution for any healthcare system.
Do we have a question? No.
Actually,
Okay, thank you.
Actually not. Just
Okay.
this skepticism that technology
Yes,
won't
thank you.
help. It's similar as for ecology and all global problems.
Thank you.
So may I ask? a
Yes,
question?
of course.
So what would you consider the main priority for transformation of health systems to make them sustainable and resilient in the future?
Yeah, it's the problem that the capital is now leading the whole world, so that we should start, as you showed us many years ago, and to try to go into the other direction, to more humanistic approaches, which is, it seems absurd at these times where capital is leading everything, but I'm afraid that this is not a solution.
Yeah. Well, I take your comment, and I understand it, and I acknowledge that there are risks, and I acknowledge that it's not the sole solution. But as I mentioned before, digital is a tool that we can use to address the underlying challenge, which is how do we get to the 60% of what actually influences our health? How do we actually address the issues of behaviors? How do we actually address the issues of where we work, the environment in which we live in? And to address that, for 70 years, my public health colleagues have been calling on us to address many of these challenges through public health approach. Over the last 30 years, we've been talking about social determinants of health. And the reason I believe none of this has worked, although scientifically sound, is because it is not part of the governance structure of health. The way the budgets are built, the way the governance model is built, is all driven by disease. What happens in most countries is you have 99% of your resources being spent on treating diseases, and 1% in the public health institute, wherever, that actually do health literacy and do some health promotions. And that is a broken system that does not work. What I am proposing here is a transformation in which we start measuring results at the community level. If we actually start doing that, we can pinpoint geographically where our problems are. As a deputy mayor in my city many years ago, I started georeferencing health data. And I started to see, for example, childhood obesity prevalence and adult obesity prevalence. And that allowed me to cross that data with poverty data, with social data. And with that, I was able to start building bike lanes exactly there. I was able to build up community-based programs to address metabolic disease in that region, and to work with schools and other institutions towards prevention programs, and to measure results as we went down the road. Was data the thing that transformed it? No. Data enabled the transformation. It's an enabler. It's available to all of us, and it makes it transparent. It makes it available for everyone to see, and it keeps politicians accountable. It keeps governments accountable. It keeps public health officials accountable on what they're doing. Not measuring is bad politics. Not measuring results is bad governance. And we are paying the result with these unsustainable health systems, with the rise of costs and the rise of disease, getting our people healthy. Instead of getting them healthier, they're getting sicker. And as we see age going forward and people getting older, what we're seeing is that those that actually have less resources, the poorest of the poor, are the ones that are going to pay the price. And so I think we are agreeing that we need to fix the human aspect of healthcare systems. What I advocate is that the technologies that are accessible to us today should be used precisely to help us accelerate and be more transparent.
Thank you very much.
Thank you.
Thank you. We'll stay with the data and we'll leave some room for Eric. So, I'll continue in Slovene. Zdravstvenih podatkov je veliko, o njih smo danes veliko spregovorili, vedno več, so seveda izjemnega pomena, a v kolikšni meri so tudi smotrno uporabljeni, o tem se bomo spraševali. Pri personalizirani zdravstveni obravnavi, torej kar najbolj po meri posameznega bolnika, bi tak pristop z bolj razpoložljivimi, vedno aktualiziranimi podatki zdravniku omogočil kakovostno podporo pri odločanju o najboljši možni obravnavi posameznika. Kakovostni in ustrezno dosegljivi zdravstveni podatki so tudi nujni za optimizacijo zdravstvenega sistema, za delovanje institucij, za raziskave, za razvoj tako v diagnostiki kot razvoju in uvajanju novih metod zdravljenja. Kajti, kot se glasi naslov naslednjega predavanja, le s podatki podprt zdravstveni sistem bo odporen in pripravljen na prihodnost. O takem sistemu bo spregovoril vodja digitalnega zdravstva pri Organizaciji za ekonomske raziskave in razvoj OECD, gospod Eric Sutherland. A data-driven healthcare system will be resilient and future-ready. Eric Sutherland.
So thank you very much. I am like my colleague that my first time in Slovenia. This is actually my first time on a stage for the last 3 years. So it's actually quite odd. Thank you. It has been a very odd several years for all of us, I know. But I come to you today from the Organization for Economic Cooperation and Development, otherwise known as the OECD. I thank Ricardo for presenting such fantastic slides about the OECD because it meant that I don't have to. My intention today, and actually the order of presentations was fantastic, because we really started laying out why we were doing this, what we need to be worrying about, and what I'm hoping to provide today are some ideas about the how we can actually move forward with some of these areas in and of itself. Let's see if this works. My role of the OECD, I've only been there for 6 months, and I come there by way of Canada. I apologize for speaking too quickly. It is the nature of being a Canadian, and apologizing is also the nature of being Canadian. So I'm sorry for anything bad that happens to any of you over the span of the day. In terms of our system itself, and I could have used electricity as my analogy for data. I choose to use the analogy of water. And I use water because it allows me to paint a picture of our fragmented systems of water captured in silos that are housed to actually do things within specific facilities and specific systems. And we've built and incented this system to be built up over the span of the last 60 years. And when we need to ask questions of these series of silos, we need to build scaffolding to connect those silos together, to connect information, to be able to answer those questions. And then we maintain that scaffolding. Sometimes we have to build a new silo. And sure, some of the stuff in there is the same as the stuff that's over here, but we want it quickly. So we're going to build a new silo as opposed to creating new information in of itself. And so what we've created is this rickety collection of scaffolding connecting old silos that aren't working together, are hard to answer new questions, can't actually respond to the needs that we have. And what we can do with them fantastically is we can create great reports about the effectiveness of our health systems 3 years after the fact. Not particularly useful. There are literally organizations that are creating reports about how systems are performing in 2019 today. The system that we have in 2023 is fundamentally different than the world we lived in 2019. So we need to be thinking about how we can be adapting our systems and evolving our systems to be able to respond to the questions that we have much more quickly and effectively. But it really is all about the questions. Riffing on where Boye was going and frankly where Ricardo was going in terms of the metrics and what is the performance of our system, it's fundamentally a question. So we need to be more focused on what are the questions we need to be trying to answer and how we can design our systems to be able to answer those questions. And yes, I would submit that Much of that is related to the data infrastructure, the ability to connect that data back and forth, but we need to be able to connect that data. So we need the water, the data, and we need the pipes that actually carry the data back and forth. Those are a lot of the digital technologies and tools, the interoperability that allow things to work together. And we also need taps that allow us to extract the data and the insights out of the systems in and of itself to actually have an effective system working together. And what happens when you have pipes and taps without water? You get a whole lot of hot air. Politicians. So, sorry. What happens when you have pipes and water with no taps? You get a lot of pressure in a system that's going to burst. And what happens when you have water and taps with no pipes? You get mud. That's not particularly useful. So what we need is to have a coherent approach across the pipes, the technologies, the water, the data, the taps, the analytics, that actually brings all this stuff together. But what we've done historically is we've actually designed those three areas idiosyncratically, not really understanding how they need to work together. And the result is we've created this monstrous mess of disconnected technologies that are not able to respond when we need them. We need to be redesigning our systems around this integrated approach from around analytics and digital and technology, I say, and data. And when we do that, then we can actually get somewhere. But importantly, I do not blame the technologists. The technologists that have actually designed the fragmented technologies, because they did exactly what they were intended to do. The problems that we have is that the policies and the incentive structures are fragmented in and of themselves. And so what we really need to be thinking about is what are the policies that are designed to achieve the end product that we want. So with that, I'm going to move a bit faster. And so I reflect on other industries have learned this. We can do pretty much whatever we want on our cell phones, except healthcare. We might be able to, you guys are lucky in Slovenia. I saw the Slovenian app earlier on today. It's fantastic in terms of your ability to get access. I wish I had that in Canada. For me to get information to my health data in Canada, I need to go to 96 different portals in order to get a comprehensive health record for myself. What? That doesn't make any sense. But these other industries have learned that by connecting their data, they can provide better customer experience, create better choice, and create the experience that the customers want in order to achieve their better outcomes. They designed their solutions around the outcomes that they wanted while achieving and staying true to their ethical things. The analogy is obviously no one would want to fly an airplane that was designed by the health system. And if you think of that, does that really give you comfort? But is that true? Think about that as we go through. When we think about health, and Ricardo touched on this, a bit of this, we need to remember why we're doing this, and a lot of this is around ensuring that we are designing around the patient, around the person. I prefer to talk about the person because a patient is, in an episode of care, whereas theoretically we are all patients throughout our entire lives, from cradle to grave. But talking about person-centeredness is really, really important, and I totally agree about how it is pervasive across the system. It's not just an afterthought at the end, it's how they are embedded into absolutely everything. And we need to be really measuring what the outcomes are, but as well as their experience and the provider experience in themselves. We can't forget about them. And we have to manage it within a cost base and ensure that equities are actually addressed. Collectively, this is known as quintuple aim, and we need to remember that as we're evolving these words and we're measuring our outcomes, which is absolutely important, we need to be measuring it, and that provides a framework for how we can actually measure things to not to ensure that we are addressing all aspects of it, that we're not creating fantastic patient experience at the cost of burning out our doctors. That cannot be a viable outcome, and frankly, something that we've experienced the last couple of years. I got my animations. So one of the things that we need to do is we need to be question-centric. We need to start with the questions. What do we want to improve? How do we actually design the analytics to actually answer that question of itself? What data can we actually gather in order to actually answer that question? What data do we need? Do we have? What can we reuse? What new data do we require? Then we worry about the technology, the design. How do we connect the systems together and actually think about all of this work? We align the human factors, and I'll talk a little bit more about that later on, but the human factors are so essential because all of this work happens because we're able to get the private sector, the public sector, the doctors, the nurses, and the patients, and all parts of the society to work together toward a common goal and objective. Whereas individual organizations trying to optimize for themselves can actually create a disastrous outcome for the whole. Again, I'll touch on that a little later on. And after we've done all this, then we can go from the point of, okay, we've collected data we've gone to the people, they have an experience, we have their data. We take the data, we turn it into information, the information turns into insight, and then the insight turns into action. And when we do that over and over and over again, but actively reusing the things that we've already done, we can start to think about the system as this ecosystem. We can start to answer new questions, or rather, we understand what questions we can answer, and when we're asked a new question, we can see, given the set of data assets we already have, can I already answer that question inherently? What is the small incremental thing I need in order to answer that new question? And that is really where I think we need to be going, is how can we leverage the myriad of data assets we already have in order to be able to advance our overall work together. So that led me to the concept of this integrated digital health ecosystem. And not surprisingly, as I was talking about before, it recognizes that we have to be worrying about the analytics that we have in the system. And yes, that includes AI. I'll touch on that a little bit later on. But it's not just the analytics from the perspective of primary care. There is primary care absolutely is the bedrock of the system. But too often in conversations, I have heard no acknowledgement of secondary uses of data around research, around analytics, around innovation, around health system performance, around measuring the effectiveness of our systems. We need to be designing our data collection, our analytic processes that allows for both the primary uses of data as well as the secondary uses of data. And goodness knows, in the last couple of years, we learned of the importance of those secondary uses of data through our experiences with COVID-19. And all of those areas of primary and secondary use are connected through this integrated health data, the ability to take what data we have, link it together, and use it more effectively. I use the term health data here loosely because, per what we've heard from both of the previous talks, the data that we require in order to answer some of these questions often will come outside of the traditional health system. It will come from the social factors. It will come from education, from social programs, et cetera. And all of these things need to come together to help us answer the questions. All of that needs to be wrapped in a layer, which I've framed as the blue, of ensuring the right security protections, the right digital protections, and the right interfaces are in place to make it easy and intuitive to use the platforms that we have. But then perhaps most important is the outermost layer, because this is where the human factors come in, that we have enough capacity in the system to do the job. We know we're facing workforce crisis across the world. But one of the interesting questions I would submit is, what if we were to activate people as health workers? What can we do? Which is not to say that we're going to fully rely upon them. Lord, that would not be the right thing to do. But there are some things that we can do in order to help people have agency in their own care. And what can we actually do in order to realize is the ultimate outcome? But a big part of that, and I don't know if you've had this experience, you can get, here's my discharge abstract, and you suddenly look at this thing that comes from after you've been released from hospital, and you can't understand any of it. It has a single word in there, carcinoma. My God, what the hell happened? And suddenly I'm talking to 50,000 people to work out what happened to me. And then when you interpret what it actually means, oh, it actually means that it's a low risk situation. It's totally fine. But a person doesn't know that because they look at the word carcinoma, cancer, oh bad, I'm going to go off and panic. So we need to, at the same time as we're doing all this, to improve the health literacy amongst the public in order to improve their ability to use these new tools and technologies that we're doing. We need to better empower providers because they have been used to, for many years, communicating only with other providers. So their communication, the language that they use, is actually foreign to the language that we would use as the public. So how can we bridge that divide to actually ensure that the right people are getting the right data and information at the right time in a way that they can actually meaningfully use it? And too often, I think we push information out and we hope that something good happens, and then frankly, disasters happen. And when disasters happen, the bad news is that it's not that you were back at zero, you're now back at negative. So you've got to actually overcome the barrier, the problems that you created for yourself, and then actually implement the solutions. I look at what happened with some of the early interventions in artificial intelligence around radiology, and in the scan they said, oh, we've detected cancers. But what they actually detected was a ruler in the image. So there was actually not an effective use of AI. It's gotten far better than that now. It actually does it reasonably well. But that's the story that people will remember from 15 years ago. Because, oh, well, I couldn't trust AI then, so why should I trust AI now? Because it's 15 years further on. The world has changed. But reminding people that things are fundamentally different. None of us had cell phones in our pockets 15 years ago. Well, maybe not none of us, but many, certainly not to the same prevalence that we have today. The world has changed. And the way that, from a health perspective, we need to be designing ourselves to be adaptable to that change. But we're also afraid of the risks. And because we're afraid of the risks, it creates this impediment that we have to make changes at the type of pace that, frankly, we have the opportunity to and potentially could demand. And I'll touch on that a bit more in a second. One of the things, and I'll touch on this briefly, is the idea of a learning health system, which is really that upper line that Ricardo showed earlier on, where every encounter in a health system is actually improving the effectiveness of the health system, both for me and my communities and for society as a whole. And that's ultimately where we want to go. And when we do this, when we create our pipes and water and taps in an effective way, it frankly will be far more cost effective because we're reusing the things that we've already done. We're reusing the investments we've already made. So many of the investments in healthcare, frankly, do not achieve their desired financial outcomes because they are not reused in the way that they were intended to. Or if they do, it's because the costs of actually maintaining those solutions are not properly considered in and of itself. So we really need to be thinking about, in this system, why is it more cost effective? How is it more scalable? And how are we able to answer the new questions that we need to on a regular basis? And what possibly most important of all this is that it is responsive to change. Because we need the ability to answer questions quickly when we need to. We had that at the beginning of COVID. And we need to have systems that are designed to be adaptable to that change. Sadly, in a system of fragmented silos, it is actually, if anything, it is the opposite of responsive. It is more concrete than anything else. And so, reflecting what we heard earlier on, what is important, and I love Boy's quote earlier on, action without vision is a nightmare. And so it is really important to ensure that as we are going into digitalization, that we're doing it in the context of where we want to go. We are not simply going to say, okay, let's take this old process and actually just create forms and digitize it, and then hey, we've digitized things. We need to re-rationalize the processes given how things are operating today. And one of the examples I will give of that is this. In one of my prior jobs, we asked, how long does it take an innovator to get access to an asset? They wanted to get access, they had consent for the patient. How can I get access to that lab data, as it turned out, in one of the provinces of Canada? And we did the process map. 18 months was the answer for one innovator to get access to one system for one patient. Not sustainable, not effective. But what this is the combination of 5 organizations coming together, each designing their own idiosyncratic privacy processes, and saying, well, we have our privacy process, so we have to follow these guidelines, and I can't trust anybody else's processes. So we have to do our own full assessment, and the amount of passing back and forth that happened ended up in this process that, frankly, forgot about the patient. I forgot about why we are doing this. This is digitizing a process. This is not creating the process that we actually need. So from that perspective, this is not about the digital and the technologies being the solution. This is about reflecting what we heard earlier on. It is about it being an enabler of the solution, but it is the human factors that will actually ensure that we use the technologies most effectively, centered on the outcomes that we want to overall achieve. And there are a number of blockers that we have. I talked about this earlier on this year. Really, where a lot of the barriers to achieving our digital future have nothing to do with technology. The most significant barriers to achieving the digital outcomes that we want is actually the people that are involved in the design and operation of our systems. So if I can leave you with one last thought, as much as we talk about digital health, and it is often associated heavily with technology as what digital health is, I would submit to you that digital health is in fact the most human of all disciplines. It must be the most human of all disciplines in order to ensure that as we're developing these new tools and technology, that we are keeping our people, the humans, in the loop and at the center and all over the whole solution in order to achieve our overall outcomes in and of itself. Yeah.
Thank you. This was very interesting, especially about after the most rainy May in Slovenia, in probably the history of Slovenia, talking about water and pipelines.
They've had a few floods in there. Yeah.
Some questions before the coffee break?
Oh, it's between people and oh, that's bad. It's not a good place to be.
Do we have a question? Or maybe you can ask Eric something during the...
I have a question
Petra,
or a comment. You mentioned the importance of health literacy. And I think that's important. However, as a patient, as a user of health services, when I read that, when I hear that, health literacy, I kind of feel that I'm expected as a patient to start learning about medicine and all the complex terminology that they're using. And you know, I'm thankful to the internet because I Googled all the complex expressions. However, what I, as a patient, am expecting, of course, is a different kind of communication with me in an understandable language. And I think also digitalization that you talk about can be a helpful tool in that respect as well, because that's the big issue for us patients, understanding all the data that's available about us.
Yeah, what I would say there is, like, historically, doctors, as I said, they're used to talking to doctors through these notes. And so they write in a language that is appropriate for doctors to talk to doctors, which is certainly at a very high university grade level. Whereas when I want to consume it, I certainly haven't had that experience. I want the terminology, now that I have access to it, to be presented to me in a way that I can actually consume. Some of that is going to be training for the doctors. Some of that is learning for ourselves, but this is actually where, and I think this may be an innovative use of things like artificial intelligence, to actually say, how can you take the complex jargon that is used by doctors to communicate and simplify the language for me? Don't change the meaning of it, but actually just write it in a way that I can more easily understand it, given my own inherent knowledge. I think that's an interesting area. I understand there are some countries and some companies that are working on those types of solutions right now. I think that's actually a real opportunity for innovation in order to bridge the gap, because in a world where we want to give patients more agency, that agency isn't going to be possible without bridging that communication gap. And is unreasonable to expect 7 billion people or 8 billion people to actually suddenly all become medical grade communicators. And so how can we actually use technologies in order to lower the requirements to entry to understand what's going on, or even just to say, here are the things that you probably are most curious about, where you should contact your medical provider. Even that as a conversation, a prompt for me, would actually be helpful in and of itself. So I think that's, in the context of future of health and innovation, that's an interesting innovation.
At this moment, some patients look for medical advices on Facebook.
Yes.
Because they can't read, they can't understand what the doctor was.
That is not unique to here. That is absolutely everywhere. I will say that the number of times, as much as I've only been with the OECD a short time, the number of times that I talk to a country and say, well, here, this is how things are, I try to comfort them saying, you're not alone. Because a lot of the problems that countries have are shared around the world, which goes back to what we heard earlier on. 80% of problems are common. And that is absolutely true. But there are big opportunities for common solutions to common problems.
Also, yes. Thank you. Eric, do we have a question? A second one?
They want coffee.
Coffee. We all need coffee. Thank you, Eric. Thank you. Welcome in Slovenia. Pol ure za odmor s kavico in še čim, tako da, ker se vsakega izziva lažje lotimo z dobro kavo, vas vabim na dobro kavo, močno, in da se vrnete nazaj čez pol urce, da rešimo še kakšen izziv, ki nas čaka tukaj v Sloveniji. Ampak se me nihče več ne posluša, ne, v tem trenutku. Tamle na moji levi čas za odmor, čez pol ure se srečamo nazaj.
Put me down upon my knees. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed.
Smo se posvetili pogledom svetovnih strokovnjakov in njihovim izkušnjam ter praksah v drugih državah sveta. Najbolj pa nas zanima, kako je doma in kako slovensko zdravstvo pripraviti na izzive, ki so že z nami, so blizu in še pridejo. Na okrogli mizi, ki sledi, bomo iskali tudi odgovore na vprašanje, kako sistem okrepiti pred motnjami, kot so naravne nesreče, pa pandemija ali motnje v dobavni verigi. Vse to smo pred kratkim doživeli. Kako razvijati načrte ukrepov ob nepredvidljivih dogodkih? Kako na take dogodke pripraviti zaloge in zdravstvene delavce? Za omizjem se nam bodo pridružili naslednji spoštovani gostje in prvega že vabim, da se mi pridruži na odru, magister Dorijan Marušič, nekdanji minister za zdravje. Bil je strokovni direktor Splošne bolnišnice Izola, magistriral na temo merjenje izidov zdravstvenih storitev in sodeloval na številnih nacionalnih in mednarodnih projektih glede sistema zdravstvenega varstva in zdravstvenega zavarovanja, plačilnih metod, izboljšanja kakovosti, nacionalne standardizacije podatkov in zdravstvene informatike in ga trenutno lahko poslušamo na Fakulteti za vede o zdravju na Univerzi na Primorskem. Pozdravljeni, gospod Marušič. Ima tudi hči z najlepšim imenom na svetu, ker je pač Martina, tako kot jaz. Z nami je tudi gospa Metka Zaletel, ki jo vabim bliže na Nacionalnem inštitutu za javno zdravje. Že dobro desetletje je predstojnica in vodi zdravstveno-podatkovni center. V času njenega vodenja je NIJZ v različnih platformah odprl svoje podatke uporabnikom in se razvil v vodilno institucijo na področju anketiranja o zdravju in tudi zdravstvenem varstvu. Aktivno tudi sodeluje v številnih mednarodnih projektih z področja zdravstvenih informacij in registrov, med drugim je vodila ali soorganizirala več delovnih paketov v skupnih ukrepih Evropske unije. Njeno delo v okviru teh projektov je tudi pripomoglo k izmenjavi znanj na področju zdravstvenih informacij med državami, odprtosti podatkov, trenutno pa se največ ukvarja z vzpostavitvijo mreže nacionalnih točk za zdravstvene informacije v Evropi. Gospa Zaletel, dobrodošli. Pridružil se nam bo tudi Mirša Poldrugovac, specialist javnega zdravja, zaposlen v Centru za zdravstveno varstvo NIJZ-ja. Tam med drugim pokriva področje ocenjevanja uspešnosti zdravstvenih sistemov in z dokazi podprto odločanje v zdravstvu. V preteklosti je deloval kot svetovalec na Ministrstvu za zdravje, kjer se je posvečal področju kakovosti in varnosti. Trenutno končuje doktorski študij na Univerzi v Amsterdamu, v okviru katerega se je osredotoča na kazalnike kakovosti v dolgotrajni oskrbi. Dobrodošli. Svoje izkušnje bo delil tudi Simon Rekanovic, specializant radiologije. Od leta 2015 tudi podjetnik, inovator na področju tehnoloških rešitev v zdravstvu, kjer njegovo delo predstavljajo medicinski podatki, njihova organizacija in analize. Je tudi direktor in ustanovitelj inštituta Viverius, ki se ukvarja z razvojem na področju digitalizacije v zdravstvu, vključen je v številne slovenske in mednarodne projekte transformacije zdravstva in vodenja zdravstvenih organizacij. To sem čisto prehitra za prevajalko. V zadnjem času pa svojo ekipo raziskuje in razvija izboljšave sistemov standardiziranega shranjevanja medicinskih podatkov in načine uporabe umetne inteligence za zmanjševanje administrativnega bremena z namenom postaviti bolnika v središče obravnave. S Simonom sva se na video povezavi enkrat že videla, ampak sem rekla, enkrat se bo še v živo, evo, pa sva se še v živo. Simon, dobrodošli. Vabim na oder tudi doktorico Tanjo Španič, zagovornico bolnikov, predsednico Združenja Europadona Slovenije in predsednico Evropske zveze Europadona. Tanja je ena krasna punca, bom rekla najprej. Za rakom dojk je zbolela pri 26 letih in dobro leto po diagnozi se je pridružila slovenski Europidoni in je od takrat njena aktivna članica ter zagovornica bolnikov oziroma bolnic z rakom, obenem pa tudi mamica, česar je gotovo najbolj vesela. Kaj ne, Tanja, se ne motim. Je vodja delovne skupine zagovornikov bolnikov pri strokovnem združenju ESMO in članica organizacijskega odbora klinične študije Pozitiv in Olimpija. Obenem je tudi članica zdravstvenega sveta pri Ministrstvu za zdravje in etične komisije na Onkološkem inštitutu. Dobrodošla. Hitim zato, da bo več časa za samo okroglo mizo, ampak prav je, da dostojno predstavimo tudi spoštovane sogovornike. Okroglo mizo pa bo vodila izredna profesorica doktorica Petra Došenović-Bonča. Predstojnica katedre za ekonomijo na Ekonomski fakulteti Univerze v Ljubljani. Njeni raziskovalni področji sta ekonomika javnega sektorja in ekonomika zdravstva. Je tudi članica Sosveta za zdravje statističnega urada in članica znanstvene organizacije The Operational Research Society. Objavila je članke, v katerih analizira in proučuje različne vidike slovenskega zdravstvenega sistema in reforme ter politike v tem sektorju. Sodeluje v svetovalnih projektih na področju zdravstva v Sloveniji in je na Ekonomski fakulteti aktivno sodelovala pri razvoju magistrskega študija Management in ekonomika v zdravstvenem varstvu. Od leta 2017 je tudi vodja tega programa in predava pri predmetih osnove ekonomike zdravstvenega varstva, ekonomske analize v zdravstvu, zdravstveno zavarovanje ter zdravstvo in zdravstveni sistemi. Z gospodom Marušičem si bosta izmenjala vlogo v primerjavi z lansko konferenco, tako da predajam kar besedo. Izvolite.
Hvala lepa, hvala za udeležbo na tej okrogli mizi. Dobili smo kar nekaj zelo zanimivih iztočnic v prvem delu dogodka, tako da se bom k tem iztočnicam tudi danes vračala. Naloga naša je, da tudi mi malo osvetlimo, kako vidimo zdravstvo, ki bo odporno na izzive prihodnosti. In ker seveda od tega zdravstva pričakujemo, da bolje in dobro naslavlja potrebe bolnikov, bomo seveda začeli z gospo Tanjo, ki sedi tukaj na moji levi. Zdaj, mi smo danes veliko slišali, da pacienti potrebujejo personalizirano, dostopno, učinkovito zdravstvo, na bolnika osredotočeno zdravstvo, a ne? Po drugi strani je pa dejstvo tudi to, da zdravstvo in zdravstveni delavci potrebujejo odgovorne, ozaveščene bolnike. Gre za partnerstvo, vendarle, ne. Uporabila sem veliko prepričljivih besed, ki jih uporabljamo veliko, ampak se nekako zdi, da jih resnično ne živimo, ne. Morda tudi pogosto ne razumemo globine njihovega pomena. Pa me zanima, zakaj menite, da je temu tako in predvsem, kako bi bilo treba podpreti tako bolnike, pa tudi izvajalce, zdravstvene delavce, da bi to partnerstvo bilo boljše.
Ja, najprej lepo pozdravljeni in hvala za povabilo ter za uvodne besede. Ja, res je, tako kot ste omenili, to so same lepe besede, o katerih poslušamo zagotovo že več kot 10 let, ampak ko postaneš bolnik oziroma kakorkoli mogoče malo neprijazno uporabnik zdravstvenega sistema s kronično boleznijo, ni tako. Vse pogosto pač postanemo neka diagnoza, ki je ponavadi neka šifra, in ta diagnoza te spremlja in vsi se ukvarjajo samo z njo, ne pa s človekom. Že prej smo v prejšnjih predavanjih slišali, kaj naj bi bilo personalizirano oziroma posamezniku prilagojeno zdravljenje in kako naj bi to potekalo. Zagotovo je to, da začnemo obravnavati bolnika oziroma osebo v celoti in ne samo diagnozo oziroma, če ima več bolezni, vse pridružene bolezni. In nekako k temu se premikamo, ne da se ne, no v nekaterih primerih lahko rečemo, da imamo tudi primere dobre prakse v Sloveniji. Zagotovo se največ na tem področju spreminja pri redkih boleznih ali pa tudi pri redkih rakih. Vse manj pa je tega recimo po nekem akutnem začetnem zdravljenju in potem, ko naj bi se posameznik tudi vrnil nazaj v družbo, ne, če je del časa odsoten. Tako da v tem, kar trenutno gledamo, ne, verjetno res več kot 10 let že govorimo o tem in imamo izjemno veliko dobrih primerov, tudi prej smo slišali, ne rabimo odkrivati tople vode, ne, ti primeri so že. Kar pri nas manjka in kar tudi opažamo je to, da dejansko ni akcije, da se ne začnejo dogajati spremembe, da nekje pač treba začeti, da ne moremo vsega naenkrat spremeniti, ampak da bo treba iti korak po koraku in pač s tem, kar trenutno imamo. In bolniki so zagotovo, oziroma smo uporabniki smo vsi. Danes jaz, jutri vi in tako naprej. Ne. In dokler v resnici ne zboliš, se niti ne zavedaš, kaj res je zdravstveni sistem in kaj imaš na razpolago. Ne. Tako da že to, da začnemo otroke vzgajati s tem in da začnemo v bistvu zelo na začetku preventiva. Veliko smo naredili na preventivi nalezljivih bolezni, tudi prej smo slišali na preventivi nenalezljivih kroničnih bolezni. Delamo, ampak ne vemo, kaj v resnici delamo. Ne. In to je zagotovo nekaj, kar bomo mogli kot družba začeti res že v vzgojnem na začetku, da bodo potem ti ljudje v odraslo obdobje to odnesli s sabo, ker odrasle bomo zelo težko spremenili. Ne.
Ste mi, če smem, dala zelo dobro iztočnico. Mi smo danes veliko govorili o nekem digitalnem prehodu, digitalni transformaciji, o tem, da je lahko digitalizacija koristno orodje, ki nam lahko seveda pri teh dilemah pomaga. Ampak na nek način se zdi, da pravzaprav bodo morda najtežje ta orodja uporabljali tisti, ki so danes v bistvu najbolj prizadeti, to so starejši bolniki. Tako da tudi ta vidik, kako pravzaprav vključiti vse, tudi tiste, ki so starejši, manj pripravljeni na uvajanje teh tehnologij, bo izziv.
Ja, zagotovo. No, to vam lahko podelim izkušnjo iz včerajšnje naše prakse. Kot organizacija bolnikov imamo tudi svetovalne telefone in tudi svetovanja oziroma podpore v živo. In pri nas v pisarni se je oglasila gospa, ki je stara 73 let in je želela imeti vem na svojemu telefonu, da bo ona zdaj videla te izvide in vse, kaj je naročena, ker se ji to zdi zelo uporabno. Ena naša kolegica je pomagala pri tem, da je dobila SMS pas, da si je to registrirala, no potem bilo pa treba to aktivirati. In mi dve s kolegico, ki se smatrava, da sva malo bolj digitalno pismene, sva ji to hotele usposobiti. No in to sva naredila tako, da sva poklicale pomoč, ki je pač tam strani upravnih enot, da so nas vodili, da sva to naredile in sva rabile recimo pol ure za to. In ko sva končale, sem si rekla, da ne vem, če bi znala to ponoviti. In v bistvu to je tisto, da mi, recimo, da sem jaz nekako rasla gor s to digitalizacijo in da mi je telefon tisto, kar mi ne vzeti, da vse drugo lahko izgubim, se ne čutim tako kompetentna. In ravno to, kako bomo te ljudi usposobili, oziroma ne vem, če jih sploh rabimo usposobiti ali jim sam raj ponudimo podporo, da jih bo nekdo peljal skozi ta sistem in da v bistvu sistem postane podpora bolniku, pacientu, in ne, da je pacient tisti, ki se mora... To je v bistvu to, kar
pri iskanju teh rešitev seveda upoštevamo potrebe teh, ki so uporabniki tovrstnih rešitev. Mogoče preden gremo naprej še eno vprašanje. Gospod Iljasa nam je dal dobro izhodišče, ko se je vprašal, kaj pravzaprav želimo, boljši zdravstveni sistem ali bolj zdravo populacijo. Mislim, da je oboje pomembno nasloviti. Tako da eno vprašanje tudi za vas, kakšno vlogo pa pripisujete tudi temu, da seveda imamo mi dolžnost zagotoviti na pacienta osredotočeno obravnavo, ampak pomembna je tudi odgovornost nas samih pacientov.
Ja, definitivno v prvi vrsti največ lahko za svoje zdravje, razen če imamo neke hude sindrome ali pa genetske okvare, naredimo sami. Pač skrbimo za svoje zdravje, zdrav življenjski slog, da se odzivamo na preventivne cepljenja, presejalne programe in da bolezen, če se pojavi, odkrijemo res zgodaj, ker v takem primeru ne rabimo veliko terapij in tudi je to bistveno ceneje ter bistveno boljše za bolnika. Jaz bi rekla tukaj, da ne rabimo toliko vseh teh lepih buzzwords, ne vem, ko se to lepo v slovenščini reče, ampak da v bistvu moramo začeti poslušati človeka in našo kulturo, kjer živimo, ker vsaj v onkologiji, kar vidimo, ljudem bistveno več pomeni kvalitetno življenje, kot pa dolgo življenje za vsako ceno. In mogoče je to tisto, kar bomo mogli začeti upoštevati, preden bomo najprej se res vprašati in potem iskati odgovore, kakor smo videli, ne pa ponujati odgovore in potem reševati vprašanja, ki se s tem pojavljajo.
Izpostavila ste dve stvari, ki so lepa iztočnica za to, da dr. Marišiču naslovim naslednje vprašanje. Izpostavila ste to, da seveda s tem, ko morda ne investiramo dovolj v preventivo, nastajajo izgube drugod v zdravstvenem sistemu. Poznamo kup študij, ki govorijo o tem, da je več kot 20% izdatkov nepotrebnih. Danes smo slišali podatke, da je 30% zdravstvenih obravnav tudi takšnih, da bi se jim lahko izognili, če bi seveda bolj zgodaj v procesu obravnave pacientu določene težave razrešili. Tako da vprašanje za vas, dr. Marušič, kako bi preprečili takšne nepotrebne izgube omejenih resursov? Vse države imamo težave s tem, da je resursov premalo, ampak to je neka stvar, ki je ne moremo kratkoročno naslavljati, omejitve vedno bodo. Tako da je eno pomembno vprašanje, morda ne toliko, kaj so razlogi za to, ker razloge kar dobro poznamo, ampak kako bi to problematiko bolje lahko naslovili.
Hvala za iztočno vprašanje, ampak zdaj si bom 15 minut za EPP. Najprej bi iskreno čestital strokovnemu odboru tega srečanja, ker je pripeljal tako 3 eminentne predavatelje. In saj zame je bil velik preskok, ker do zdaj sem mislil, da sem utopist, da vem, da sem idealist. Zato, ker obstajajo ljudje, ki podobno razmišljajo kot neka skupina ljudi tudi v Sloveniji. Torej, slišal sem zelo veliko o zdravstvenih sistemih, ampak praktično sem štel manj kot 5-krat bolnišnica ali zdravstveni dom ali podobno. Izrazoslovje torej o strukturi praktično ni bilo govora, nekaj malega o procesih, bistveno pomembno je bilo pa o rezultatih. Torej, če želimo najprej teh 20% zmanjšati, bomo začeti miriti, kaj počnemo, da bomo lahko začeli nekaj zmanjševati. Kako do tega priti? Tako da naredimo enorm preobrat v našem razmišljanju, verjetno najprej z spremembo načina pogovorov. Danes smo slišali, da se v zdravstvo investira, ne pa da se zapravlja sredstva v zdravstvo in da verjetno je pač potrebno začeti skrbeti o zdravju. Tako da na nek način bi moral biti osnovni cilj, kako čim bolj zmanjšati razliko med zdravimi leti življenja in pa pričakovano življenjsko dobo. Skratka, če bi to bil glavni cilj, bi potem verjetno imeli prazne bolnišnice, ki bi jih tudi financirali, imeli bi ambulante družinskih zdravnikov, ki bi imeli morda po 5-6 res obolelih pacientov, drugi vsi bi bili preskrbljeni in tako naprej, da ne govorim, to je seveda utopija. Ampak v vsakem primeru kot prvo moramo spremeniti zdravislovje. Kot drugo moramo začeti proces od promocije preventive in naprej skozi kurativost, od primarne in vseh silosov, ki so v zdravstvenem sistemu,
V bistvu že prognostike.
začeti spreminjati. Spreminjati način pristopa, dela, nagrajevanja in podobno, da bi lahko prišli do tega, da bi na koncu začeli meriti rezultat z vidika pacienta in pa tudi izvajalca in da bi dejansko pogledali, kako in kaj. Mene je zelo veselil slajd, ki je bil o, pa ne zato, ker sem moški, ampak o raku prostate, ampak ta enak sliko vrtimo mi v Sloveniji že 2 leti, verjetno ne z takim odzivom kot danes, ampak to je cilj. Pa morda še tako, da bom bolj igriv, taki slajdi bi bili pomembni, da bi ženske se lažje odločale, kam bodo može poslali na operacijo. To bo tudi nekaj pokazalo zvestobi. Skratka, ker govorimo danes o podatkih, bi morali začeti postavljati sistem v novem okolju, z novo paradigmo, z spremljanjem procesov in merjenjem celotnega postopka naravnanega za to, da zmerimo rezultate in potem ne bo to glavno vodilo pri reorganizaciji zdravstvenega sistema. Vse tiste napovedi o tem, koliko bo demografski šok, koliko bo neobrnjena piramida, ki jo nam ne uspe obrniti, nove tehnologije in podobno, ko se obrnemo v relativni svet, je to zelo preprosto. Torej, določen delež bruto družbenega proizvoda bomo namenili za zdravstvo, pomembno je samo, ali s tem dejansko dosežemo bolj zdravo družbo. Torej, bom nekako dal zaključil to misel, ali je teh 70 milijonov, ki je bilo namenjeno za stresni šok ali kakorkoli, vrženo stran ali ne. Odgovor moj je, da vsi ti, ki analizirajo, bi težko prešli skozi srednjo šolo. Dejstvo je, da pravi rezultati bodo vidni čez leto 2, 3, 4, 5. Če se bo zdravje Slovencev izboljšalo, da bojo bolje videli, ker so oftalmologi bili najbolj pridni, bo potem ta denar bil ustrezno vložen. Nikakor pa ga ne moramo meriti, ali je bil javno-zasebno izvajalec nagrajen, ali je bilo več oftalmoloških pregledov. Skratka, kaj je bil rezultat te investicije 70 milijonov? In nažalost te diskusije še nisem slišal. Spet politična diskusija, obmetujejo se tisti, ki o zdravstvu vedo, niti da se piše ZZ.
Vi ste tudi del skupine, ki je pripravljala usmeritve za uvajanje na vrednosti temelječe zdravstvene obravnave v Sloveniji. In danes je meni tudi dala ta diskusija eno novo informacijo. Mi smo se precej pogovarjali o kazalnikih izidov, ki so relevantni za paciente. Slišali smo tudi danes govora o premijih in promih. Ampak ena stvar pa mislim, da je manjkala do zdaj v diskusiji, je pa zelo pomembna, je bila izpostavljena danes, to so pa tudi tako imenovani community-based outcome measures. Gre za vprašanje ne samo merjanja izidov na ravni pacienta, ampak dejansko tudi vključevanje tega širšega pogleda skupnosti.
No, v smernicah in tudi potem v slajdih, ki smo predstavili, smo to omenili ampak to se nam je vseeno zdelo tudi za časa mojega življenja verjetno težko dosegljivo, čeprav po drugi strani bi bilo lahko v Sloveniji to bistveno lažje, ker na nek način imamo zelo močno lokalno samoupravo glede upravljanja, torej imamo občine, imamo celo na nek vidik zdravstvene regije in bi se lahko tega lotili nekoliko drugače, če bi imeli zdravju naklonjene ali pa pozitivno zdravju naklonjene župane. Bolj ali manj jih samo zanima, ali bojo končali zdravstveni dom, ali bo šola obnovljena, da bodo pa učence v osnovni šoli pa celo v vrtcu učili, kaj je zdrav način življenja, da starše morajo učiti, da ne kadijo, da se morajo veliko gibati in podobno. Tega je še daleč. Skratka, tudi v celotni družbi mislim, da smo bolj ali manj v strukturi, procesi se malo nakazujejo, rezultati so pa še zelo, zelo, zelo daleč.
Zdaj ste mi dali spet lepo iztočnico, pa kar za vas, gospa Metka. Veliko smo se pogovarjali o podatkih. Danes je dr. Marušič izpostavil, da seveda bodo v bodoče bolj pomembni procesni kazalniki, predvsem kazalniki, ki kažejo rezultate. Zdaj, vi prihajate z Nacionalnega inštituta, podatke zbirate že leta, tudi veliko analiz pripravljate. Pravzaprav imamo posamezniki včasih že občutek, da smo informacijsko preobremenjeni, da imamo podatkov celo preveč, ne premalo. Ampak dilema pravzaprav je, gre res za informacijsko preobremenjenost ali gre le za to, da podatkov ne uporabljamo na pravi način, filter failure, angleško temu tudi rečemo. Tako da je pomembno vprašanje za vas, kako zagotoviti iz teh podatkov, ki jih imamo, promptno informacijo odločevalcem. Danes je gospod Erik lepo povedal, da imamo sisteme danes, ki nam omogočajo, da po 3 letih ugotovimo, kako smo delali. Za zdravstvene sisteme pripravljene na izzive prihodnosti, seveda je to absolutno prepozno. Mi rabimo to informacijo takoj, tako da eno vprašanje za vas, kako bi izboljšali podporo odločevalcev z vsemi podatki, ki jih zbiramo.
Ja, hvala lepa. Bi se tudi jaz najprej zahvalila za vabilo na to zanimivo okroglo mizo. Zdaj, že v toku pogovora in prej med prezentacijami sem dobila res veliko iztočnic, pa sploh ne vem pravzaprav, kje bi se lotila tega, ampak dejstvo je, da Slovenija ima in je imela že v preteklosti ogromno podatkov. Zdaj mogoče raven danes, ker obeležujemo tudi 100-letnico NIJZ-ja, ima NIJZ na svoji spletni strani tudi en tak lep časovni trak, odkudar je razvidno, od kdaj že vse zbiramo podatke. Se pravi, podatkov je definitivno veliko. Imamo seveda še informacijske luknje, recimo incidence in prevalence posameznih bolezni so še vedno tiste stvari, ki jih poskušamo krpati z različnimi informacijskimi viri, pa včasih nismo zadovoljni s tem, kar dobimo. Ampak, kot je pa tudi razvidno iz razprave, imamo pa cel kup nekih informacijskih, da bi tako rekla, gora, ki pa še niso, ki pa dejansko še niso prišle očitno do tistih, ki bi jih potrebovali. Zdaj, eno od teh, ki bi jih jaz danes omenila, so prav gotovo PREMSI, se pravi Patient Reported Experience Measures. NIJZ to zbira že od leta 2019 v zunajbolnišničnih, specialističnih obravnavah in v bolnišničnih. Zdaj moram reči, da izvajalci to s pridom uporabljajo, nismo pa še prodrli s temi podatki tako daleč, da bi se dejansko na nacionalni ravni resno uporabljali. So pa to zelo pomembni in tudi zelo zanimivi podatki in res izvajalci so v bistvu nad njimi navdušeni. Druga stvar, ki je bila zdaj omenjena, ta je community-based, moram tudi omeniti en produkt NIJZ-ja, Zdravje v občini, s katerim smo začeli v letu 2016. To mogoče poznate, če kdaj pogledate svojo občino, ampak en del tega je tudi nagrada Občina zdravja, kjer sodelujemo z Gospodarskim vestnikom oziroma projektom Zlati kamen in na ta način poskušamo spodbujati župane, da jim ne bi bil pomemben samo asfalt, ampak dejansko, kaj oni vložijo v zdravje. Ker dejansko zdravje nastaja tam, kjer živimo in kjer delamo in zato je to, kar župani vlagajo v zdravje, izjemno pomembno, če gledamo ta preventivni vidik. Zato so župani pravzaprav zelo se jim zdeli fajn, ko smo prišli enkrat do te občine zdravja in tisti, ki jo vsako leto pač ena občina prejme to nagrado, jo tudi s ponosom pokažejo in recimo v naslednjem letu bomo začeli tudi objavljati, kaj so te občine naredile boljš in kaj več so naredile za zdravje svojih občanov. Sicer pa, če se vrnem nazaj na podatke, ki jih imamo, pa ki jih nimamo ali pa ki jih ne znamo dovolj dobro prezentirati, moram reči, da tukaj imamo več nekih slojev, ki so pomembni. En sloj je to, kako recimo odločevalci uporabljajo te podatke. Zdaj od tega, da pravzaprav kar nekaj let nazaj je bilo kar veliko ukrepov sprejetih brez podatkovnih podlag, s tem, da so navzoči ministri izvzeti, seveda, do tega, da recimo ministrom ali pa odločevalcem zadoščajo take preproste tabele, grafi, tudi interaktivna grafika in zdaj prihajamo v neko tretjo fazo, kjer se bo izkazalo, da to vrstne analize seveda niso dovolj, ampak da je treba na podlagi podatkov, ki jih imamo, zgraditi modele, ki upoštevajo veliko več dejavnikov kot ene preproste tabele. Zdaj, izziv, s katerim se tukaj soočamo, je pismenost. Zdaj ne govorimo samo o zdravstveni pismenosti, ki je zelo pomembna za paciente in vse, ki se soočajo z zdravstvenim sistemom, ali kot zaposleni, ali kot uporabniki, ampak zdaj, ne vem, težko rečem, da je to tudi statistična pismenost, kako razumeti podatke in kako tudi prav, da tako rečem po narekovaji, naročiti podatke, a ne, ker recimo tipično je, da mi ministra ali pa ministre zasipavamo z gorami enih tabel, ampak iz tega pravzaprav, mislim, to so drevesa brez gozda, a ne, in zato je v bistvu to vrstna pismenost izjemno pomembna.
Še ena stvar, ne? Pri kazalnikih je tudi zelo ključno, da pravzaprav lahko razumemo, kaj nam kazalnik komunicira. Če rečemo, da v Sloveniji 9,2% bruto domačega proizvoda namenimo zdravstvu, nam ta številka ne pove prav dosti, če se seveda ne primerjamo skozi čas in pa z drugimi državami v EU. Ena pomembna stvar pri kazalnikih je tudi to, ne, da imamo primerljivost ne samo med izvajalci znotraj Slovenije, ampak tudi mednarodno. Tako da zdaj se veliko govori tudi o naporih vezanih na ta enotnejši podatkovni prostor. Kakšne potenciale vidite v tem? Pa ne samo za raziskovalce. Raziskovalci se mi zdi, smo prvi, ki vrednost podatkov na ta način pripoznamo, ampak tudi za odločevalce in ne nazadnje tudi za posamezne izvajalce.
Ja, Evropski skupni zdravstveni prostor oziroma European Health Data Space, ki se pripravlja in bo verjetno v letošnjem letu uredba sprejeta, prinaša pravzaprav dva dela. Eden je primarna raba podatkov, drugi pa sekundarna raba, no, ampak mogoče, če pogledamo najprej na kratko primarno rabo, ta del se saj za Slovenijo, tukaj Slovenija je že zelo napredna pravzaprav, a ne, vemo, da imamo CRPP, ZVM in tako naprej. In tukaj bo EHDS še bolj podprl želeno standardizacijo in v bistvu to primerljivo z drugimi državami. A ne. To je nek bistveni korak plus čezmejno sodelovanje. Se pravi, čezmejna izmenjava povzetka podatkov o pacientih, to je tisti korak, ki si ga želimo in ki bo tudi v bližnji prihodnosti udejanjen. Medtem ko drugi del za sekundarno uporabo, se mi pa zdi, raziskovalci v Sloveniji že zelo vejo, kje v Sloveniji so podatki, bo pa EHDS pravzaprav omogočil dostop slovenskih raziskovalcev do tujih podatkov, raven, kjer spet govorimo o primerljivosti, a ne. Po drugi strani pa, kolikor jaz poznam, v Sloveniji obstaja tudi kar nekaj inštitucij, ki zbirajo razne zdravstvene podatke, pa jih nimajo na tako transparenten način objavljenih in mora tudi raziskovalec danes zelo dobro poznati, koga mora vprašati, da dobi te podatke. EHDS pa vpeljal enotni nacionalni katalog, kjer bojo razvidni vsi podatki. Tako da tudi z tega vidika se mi zdi, da bo EHDS lahko prinesel kar nekaj pozitivnih stvari.
Zelo veliko smo danes govorili o tem, ne, kako podatki, ki jih pretvorimo v smiselne informacije, koristijo odločevalcem. Zdaj, ali so to Ministrstvo za zdravje, ali je to plačnik. Danes smo pa v prezentaciji na primeru Portugalske zelo lepo videli seveda, da uporaba podatkov, ki kot povratna informacija zdravstvenim delavcem brez dodatnega vloženega evra dosega seveda izrazite rezultate. Študije kažejo, da so nefinančne spodbude do 4-krat močnejše in vplivajo na to, kako izvajalci opravljajo svoje delo. Tako da se mogoče navežem na vas, dr. Kanovič, ker ste pa seveda iz vrst izvajalcev, ne? In ste tisti, ki zbirate ali pa posredujete ogromne količine podatkov naprej, pogosto verjetno frustrirani potem ravno s to povratno informacijo, ki pride ali ne pride nazaj, ne? Danes smo slišali data for better lives, včasih imamo občutek, da vsi ti podatki zdravnikom pa zdravstvenim delavcem v prvi bojni liniji ne olajšajo življenje, ampak ga včasih otežijo. Kakšni so izzivi, ki jih vi vidite, ali imate kakšne primere pa nekih digitalnih rešitev, ki jih že imamo, ki so vam pa res olajšale delo in vam dale več časa za pacienta?
Ja, ok, hvala za besedo, pa tudi hvala za vabilo. Grih prej smo za hec rekel, da verjetno noben drug ni imel časa, pa sem pač jaz prišel. Ampak drugače pa ne, se pravi, zdaj še glede teh podatkov, ne pa še radiolog sem, pač pri nas pa res je veliko teksta. Ok, če se najprej usmerim čisto na to, kar se trenutno podatkov tiče, pa poenotenosti, malo je to tudi moje področje, ti na koncu kar malo zmanjka, kaj bi sploh človek še dodal to zraven. Najprej bi sam en, po moje, mit razblinil. Jaz mislim, da ogromno se govori o tem, da tako posamezniki, kot recimo na splošno zdravstveni delavci, da obstaja nek tak splošno odklonilen odnos do, recimo, digitalna orodja, da bo malo bolj preprosto. Nisem čist prepričan o to, ker če malo pogledamo, vsi nekako uspešno uporabljamo touch telefone, večjih težav ni, dobro, zdaj, recimo, moj oče star malo čez 80, se malo lovi, ampak na Facebooku je bolj suveren kot jaz. Tako da, čist z vidika same uporabe splošno dostopne tehnologije nismo tako, nam ne gre tako slabo. Pol pa so situacije, kjer gre tudi meni, ki se s tem ukvarjam, zelo slabo. Sem se tudi matral. Tako da to je čist tak prvi, po moje, tak mit, ki pa se zelo rad poudarja, zato ker se pol zadeva izpade malo bolj fantastična, malo bolj je zanimivo, malo bolj je dramatično, češ nobeden noče računalnika uporabljati. Kar se tiče pa same res pa narave uporabe, je pa res moteče pri teh količinah nepoenotenih podatkov. Ampak se tule zadnje čase toliko veliko dogaja, se pravi, sem 5 let zdaj, kar sem res, da sem aktivno zdravnik, toliko veliko dogaja, da če vam jaz povem, da malenkosti delajo ogromne spremembe, se bolj spet hoče to izpasti zelo fantastično, malenkost je nek nov app z uporabo AI-ja, ki bo prebral izvid. Ne, malenkost, jaz sem bil nedeljo dežuren na urgenci, prišla je gospa z hujšimi težavami bolečine v prsih, torej stanje je dovolj nujno, da je resnično nujno in vsi podatki okrog tega so zame lahko v trenutku pomembni. Tudi če niso agregirani, je moment, ko jaz rabim malo časa, da dostopam do CRPP-ja, preberem kakšen izvid, pa to, te trenutki so ključni. In malenkost, ki se je zgodila, pa ne vem kdaj, ampak v zadnjem obdobju je, da jaz nisem rabil več tokrat prositi za dovoljenje za vpogled službi NMP, ampak mi je bil ta dostop odobren. To se večini zdi, to je 2 klika, ne. Meni je to ogromna razlika. Pa je bila na videz tako majhna, tako da spet, kar se tiče podatkov, ja, smo resnično bombardirani s tem in res je tega veliko, ampak majhni koraki v smeri tudi razne agregacije, raznih dodatnih možnosti, razvoja, e-zdravja v našem primeru, se mi zdi, da dodajajo kar veliko sami obravnavi. Kar se pa še kakšen konkreten primer, pa novih splošno uvedenih rešitev pa tiče, bi pa recimo jaz kot radiolog rekel, da za marsikoga si mogoče ne zna predstavljati, koliko veliko razliko naredi meni, ko pišem izvid za nekoga primerjavo, dajmo poenostaviti, nek karcinom enega dela telesa in moram to primerjati za 3 tedne staro preiskavo, pa 3 mesece staro preiskavo, za kar potrebujem 2-3 telefonske klice, kljub temu, da imamo teleradiologijo, super, ampak že samo, ko pa odmakneš to, če bi to bilo meni avtomatsko na voljo znotraj istega porabniškega vmesnika, kako te majhne stvari naredijo ogromno razliko. In ker to že postaja možno in ker gremo v tej smeri, so te spet na videz majhne, daleč od umetne inteligence, ki bo izvid namesto mene napisala, ekstremno pomembne. Še bolj bi si pa rekel, da so pomembne za pacienta, ker nivo oskrbe, ki ga pola dobi, je logično boljši, Še toliko boljši, če jaz v časovni stiski te primerjave ne naredim. To je pa naša realnost. Tu bi pa sam tako dodal pa malo soli na to lepo, tu pa je malo te realnosti, da zaradi vsega tega, ker se je včasih tudi prej zgodilo, da sem pa rabo dodatne klike za dostop do kakšne dokumentacije, tega tako sam, kaj šele kolegi, ki so še precej bolj obremenjeni, pa mogoče še manj tehnično vešči, pač niso naredili.
Ja, ena stvar je digitalne kompetence in mislim, da se strinjamo, da so mnogi v zdravstvu seveda te digitalne kompetence razvili, saj smo bili primorani v to, da smo jih razvili. Ampak se mi zdi, da morda gre bolj za frustracijo zdravstvenih delavcev ravno pri potem uporabi teh podatkov, ki jih potrebujemo. Pa še ena stvar je, vendarle se nam okolje zelo hitro spreminja. Zgodile so se nam in tehnološke spremembe in epidemija in tako naprej. Tako da mogoče lahko se navežem na kolega Poldrugovca. Ena od pomembnih ovir, mislim, da je bila tudi danes predstavljena na prosojnicah, je tudi ta strah pred spremembami, nezaupanje v to, kaj te spremembe pripeljejo. Tako da vprašanje tudi za vas, kako bi vi ocenili raven sodelovalne organizacijske kulture v zdravstvu, zakaj imamo take ovire ali pa tak strah pred uvajanjem teh sprememb? Je to povezano še z, ne vem, preveliko hierarhijo v slovenskem zdravstvenem sistemu? Kako bi to oviro, to premagovanje strahu ali pa odpora preprečili? Ker očitno usposabljanje samo in razvoj digitalnih kompetenc ni dovolj.
Ja, hvala za vprašanje. Jaz bi se navezal na besedo nezaupanje v tem smislu, da mislim, da je prav ta ključna v tej razpravi. Zdi se mi, da obstaja v našem okolju, kot verjetno pač v vseh, v večji ali pa manjši meri nek odpor do sprememb, težko do teh sprememb pride. Iz mojih izkušenj kot državni uradnik na Ministrstvu za zdravje najprej in potem na Nacionalnem inštitutu za javno zdravje nisem imel občutek, da je glavna pomanjkljivost pomanjkanje podatkov. Seveda bi želeli jih več, boljših in tako naprej za vsako odločitev, vendarle se mi je zdelo, da pogosto tudi takrat, ko podatki so bili na razpolago, ko nekako smo vedeli vsaj, kakšna so priporočila stroke, glede tega, kaj je potrebno narediti ali pa spremeniti, spremembe so počasne, če se sploh pač zgodijo. In po mojem mnenju pač tukaj gre dejansko za eno težavo v, bomo rekli temu, upravljanje, governance v angleščini, ena od besed, ki se tudi občasno uporablja, je vladovanje, v načinu, kako sprejmemo te odločitve oziroma skušamo doprinesti spremembe. In tukaj se mi zdi, da v nekem hierarhičnem pogledu si pogosto predstavljamo, večina izmed nas deležnikov, kakor je dr. Španičeva povedala, v bistvu smo vsi na nek način deležniki v zdravstveni sistem, imamo en občutek, da je odločanje o spremembah v zdravstvenem sistemu zelo hierarhično. Morda pač, če nekoliko karikiram ali pa pretiravam, imamo to predstavo sindroma odrešenika, da zdaj pa pač bo minister, kdorkoli že to bo, vse zadeve pač rešil sam. In zdi se mi, da realnost v našem zdravstvenem sistemu je takšna, da je moč o odločanju bistveno bolj razporejena med deležniki. In da različne organizacije, Zavod za zdravstveno zavarovanje, Združenje zdravstvenih zavodov, posamezni pač izvajalci, organizacije pacientov, NIJZ, skratka imamo en kup enih deležnikov v sistemu in vsak ima svoj vpliv na zdravstveni sistem. To je pač v bistvu omrežni način odločanja ali pa governance, ki se zoperstavi na nek način temu hierarhičnemu. To je načeloma dobro, je pač od to, kar želimo doseči z demokratičnim sistemom, da pač ni samo eden, ampak različni interesi privedejo do nekih skupnih odločitvah. Vendarle, da je to skupno odločanje uspešno, zahteva zaupanje med deležniki, med akterji. In tukaj se mi zdi, da smo na nek način malo kratki, da nam manjka medsebojno zaupanje. V praksi se mi zdi, da se to odraža v tisto, kar je na primer gospod Lejte prej izpostavil o javnih uslužbencih, ki grejo v zasebni sektor, ker se ne počutijo spoštovani, ker nimajo občutek, da jim sistem ponudi tisto, se ne odziva na njihove želje in potrebe oziroma niso razvili en takšen odnos zaupanja. In ta odnos zaupanja potem bo omogočalo deloma prevzem soodgovornosti za sistem. In torej to, da bojo vsi deležniki in se počutili soodgovorni in ne bojo videli le v ministra ali pa v ministrstvu ali pa v vladi edini odgovorni nosilec za sistem zdravstvenega varstva.
Bom tukaj malo skočila. Vi ste se v karieri ukvarjali tudi z dokazi podprtem odločanju, evidence-informed policy making. In to je koncept, o katerem se že leta pogovarjamo, pa se zdi, da v Sloveniji to ne deluje najbolje. Zakaj mislite, da je to tako? Kaj bi priporočili? Zakaj se tega lotevamo napak?
Torej, eden od mitov, ki jih je, se mi zdi na nek način potrebno razbliniti, je to, da dokazi podatki ali pa pač znanstvena literatura nam lahko ponudijo odgovore v smislu konkretne rešitve, ki jih je potrebno uvesti. To je tehnokratski pogled, ki nekako je kratek v tem smislu, da ne upošteva, da imamo različne vrednote, pač pričakovanja, cilje, ki so v končni fazi pač politični. Politični ne v ožjem smislu, ampak v smislu pač deležnikov, ki vsak ima pač svoje cilje. In tukaj se mi zdi pač ključno prepoznavanje točno to ločnico. Se pravi, je en trenutek strokovne razprave, en trenutek, ko iščemo, kaj tehnično je možno in od teh možnosti, kakšne bojo posledice ali verjetni rezultati, glede na to, kaj nam znanost in podatki povejo, in po drugi strani odločitev izmed teh možnosti, kaj je tisto, kar v bistvu si želimo, kakšno družbo si želimo. In če ne ločimo eno in drugo, potem bi rekel, da primer, ki mi pride zdaj na pamet, nutrije. Danes smo vsi eksperti za nutrije. Pomembno je ločiti, kje je strokovna razprava o biološkem okolju in potem pač politična odločitev, kaj želimo doseči in tako naprej. Ampak mešanje obeh se mi zdi, da potem privede do ali napačne odločitve ali pa pač do neodločanja.
Oziroma sprejemanje odločitev, ki dejansko v bistvu niti ne upoštevajo stroke. Hvala lepa, mi smo pretekli prvi krog z našimi gosti, ker imamo seveda čas omejen, bi morda na tem delu odprla možnost, da se v razpravo vključite tudi vi, tako da prosim, da morda našim sodelujočim zastavite kako vprašanje. Vidim vas pa ne najbolje, ker ste v temi, mi pa osvetljeni. Ja, mislim, da gospod First.
Zastopnik pacientovih pravic z Gorenjske. Samo eno kratko vprašanje. Veliko se danes govori o podatkih, o zaupanju v podatkih. Recimo, jaz se dnevno s tem vprašanjem srečujem, me kličejo pacienti, pa bolnica ima objavljeno, bi rekel, v 30 dneh bom prišel na vrsto. NIJZ bi ima pa čist nekaj drugega. Kako pride, bi rekel, do te diskrepance? Te informacijski sistemi niso, bi rekel, kaj bi rekel, v soglasju, ali je zajemanje podatkov drugačne? Hvala.
Vprašanje za gospod Zaletel zagotovo, čeprav smo ga že malo tudi načeli, kar izvolite.
Zdaj, konkretno v zvezi s čakalnimi podatki, ki jih ima NIJZ objavljene na svoji spletni strani v zvezi s čakalnimi dobami pri posameznem izvajalcu, izvirajo točno od tega istega izvajalca. Se pravi, NIJZ tega nič ne predeluje, nič drugega ne dela s tem. Samo to, če se te dva podatka razlikujeta, to samo pomeni, da podatek, ki ga ima on na spletni strani, ni ažuriran z njegovim lastnim sistemom, a ne nič drugega. Tako da, ne vem, mislim, zelo težko je sploh, recimo, ker ste rekel, da prihajate z Gorenjske, recimo Splošna bolnišnica Jesenice ima itak 3/4 terminov, ki jih določa za paciente kot okvirne termine, a ne. Tako da to je cel sklop povezanih težav, ampak dejansko te podatki izhajajo od izvajalcev in za njihovo kakovost so tudi odgovorni izvajalci.
Pa če se smem mogoče jaz malo navezati, vi ste izpostavili vprašanje kakovosti podatkov, a ne? Ena od pomembnih stvari, ki vpliva na kakovost podatkov, je tudi ta povratna informacija, ki je tisti, ki dajemo podatke, dobivamo. A ne? Izvajalci, tako kot smo se prej pogovarjali, veliko podatkov zbirajo, če ne dobijo povratne informacije, zakaj se ti podatki uporabijo, ne? Katere odločitve na tem temeljijo, zagotovo to seveda tudi znižuje kakovost podatkov. Dr. Marušič.
Ker danes veliko govorimo o podatkih, je treba sve poudariti, da iz podatkov nastanejo informacije. In ravno v tem koraku je, kdo bo iz podatkov kreiral informacije. Ali imamo tu dovolj znanja, ali imamo tudi pravilne ali pa prave naročnike informacij.
Ali si zastavljamo prava vprašanja, ne?
To je to. Ali si postavljamo. Zdaj, ker je bil tolikokrat napaden Zavod za zdravstveno zavarovanje Slovenije, ki je objavil število opravljenih storitev po zdravnikih, končno sem to doživel na slovenskem nivoju. Ne povem, da točno pred 25 leti sem bistveno boljše informacije podal svoji predstojnici. Namreč podal sem, koliko je kdo naredil, kdaj je to naredil, v rednem delovnem času ali v dežurstvu, ali je bil to pregled, ali je bila diagnostični postopek in podobno. Skratka, kdorkoli je to naročil, je moral imeti nek cilj, Lahko zaključim samo, da je imel zelo namiren cilj. Zato, ker je razburkal slovensko javnost tako strokovno kot nestrokovno. Tako se pač s podatki ne sme početi. In to opozarjam zaradi tega, ker če bomo prišli na merjenje rezultatov in jih bomo vrgli na splet, se ne predstavljam, kako se bodo odločali Slovenci, ko bo v nekaterih bolnišnicah umrljivost 90% in bo to 2% manj kot recimo slovensko povprečje. Kaj bomo naredili s tem modelkom in tako naprej. No, v skupini smo pripravili predlog, kako bi se počelo, ampak opozarjam, da določene podatke bo potrebno zelo tankočutno analizirati, informacije pravilno posredovati politikom, odločevalcem, strokovni javnosti, vsem ostalim, da bomo prišli do pravih odločitev. Sicer bomo na vrat na nos zapirali oddelke ali bolnišnice, ki imajo lahko optimalen volumen ali nizek volumen. Recimo, imeti nič zapletov pri 2 operacijah na leto je umetnost. Moraš samo 2 zelo lahko zbrati, pa je. No, take so številke za operacije prostate v eni od bolnišnic v Sloveniji, 2 na leto. Torej, če bomo samo povedali umrljivost brez številke operiranih, kdo je operiran in tako naprej, bomo spet zavajali.
In brez aktivnosti pacientov.
Podatki so osnova za informacije in to je zelo pomembno, ne samo za odločevalce, ampak tudi za uporabnike.
Gospod First. Imamo še kako vprašanje publike? Ok, hvala lepa. Potem nam tu ta preostali čas, ki ga imamo, to je še 10 minut, daje dovolj časa, da vas prosim za zaključne misli, ko strnete vse, kar ste danes slišali od uvodnih govorcev, pa do naše razprave na okrogli mizi, pa bomo kar po vrsti, mogoče prosim vas, dr. Marušič, za prvo zaključno misel.
Jaz bom najprej povedal, da sem zelo užival na današnjem srečanju, ne zato, ker sem na okrogli mizi, ampak ko sem poslušal tako 3 eminentne mednarodne strokovnjake, ugotavljam, da le ni tako velik razkorak med nekaterimi v Sloveniji in med mednarodnim prostorom, ne glede na to, kakšne so informacije iz podatkov, ki jih imamo. Ne nazadnje, Slovenija je, mislim, da svetovni evropski prvak v najnižji umrljivosti novorojenčkov, mimogrede, ker se je kolega iz Portugalske hvalil. Ampak mi se s tem ne znamo hvaliti, hvala Bogu, da imamo Rogliča. Ampak torej, najprej sem zelo užival. Druga stvar, kar je, nekatere številke sem si zelo zapomnil, da sedaj sem vedno povedal, da je 20% tistega, kar pri našem zdravljenju naredi zdravstveni sistem, 80% vse ostalo, danes sem vedel, da 30% je genoma. In tega mi Slovenci ne bomo mogli spremeniti. Slovenci in Slovenke smo rojeni nezadovoljni. Zdaj Roglič, kljub temu, da je zmagal 4-krat, nima Tour de France. Nima Tour de France. To je sporočilo enega od teh. Ne, da je zmagal 3-krat Vuelto, 1-krat Giro d'Italia, nima Tour de France. Kakšen kolesar je to? Skratka, enako kot govorimo, zakaj ne spremenimo v Sloveniji v zdravstva, ne spremenimo šolstva, ne spremenimo visoko šolstva, ne spremenimo sociale. Mi se že 25 let pogovarjamo o dolgotrajni oskrbi, malo vsi snovalci je ne bomo potrebovali več. Tako da, to je v našem genomu, da se borimo proti kakšnikoli spremembi. Zato pač bom moral zelo utopistično, idealistično povedati, moramo začeti spreminjati besede. Beseda je konj. Torej, moramo začeti govoriti popolnoma drugače. Ne več o boleznih, ampak o zdravju. Moramo začeti investirati v zdravje. Moramo drugače stimulirati državljane, državljanke in tako naprej. Kako do tega pristopiti?
Vi ste na začetku lepo rekel, da je naš cilj to, da podaljšamo zdrava leta življenja. Hudič pri zdravih letih življenja je to, da je en del tudi subjektivno ocenjena, kar seveda pomeni, da glede na naravo Slovencev bomo vedno malo slabši kot pa drugi.
Sej to je to, ko primerjate Slovenijo po vseh podatkih, ki jih imamo, smo meni najslabši v tem, kako smo zadovoljni s svojim zdravjem, kar je nerazumljivo. Še celo čakalne dobe prenesem, ampak zdravjem pa nismo zadovoljni. Skratka, mogoče moramo ostati pri tem, kar je naša zgodovina, torej Slovenija, kot vemo, odkot je nastala, je zdravstveni sistem slonel na primarni ravni. In če ne bomo na tem ustrajali, slovenski zdravstveni sistem tako ali tako ne bo preživel. Tako da recimo primarcem rečem, dejte že enkrat spremeniti količnike, ker je nedostojno, da Slovenci merite v količnikih iz leta 85. To je tako, kot če bi Roglič tekmoval na koledar. Približno. Tako merimo. In to je prva stvar. Druga stvar, kar je pač potrebno, se zahvaljujem kolegici, ker se veliko skupaj, da uporabimo prav. Jaz sem do lani uporabljal narobe, da postavimo pacienta v center. Ne, moramo se osredotočiti nanj. Torej, on naj postane glavni pacient, klient in kakorkoli želite. Na letalih sem vedno jaz glavni pacient ali klient. Najbolj sem bil fasciniran zadnjič, ko me je pilot pozdravil na vratih. Kar počne tudi sam kot zdravnik, vsakemu dam roko. Skratka, osredotočiti se moramo na pacienta in začeti moramo meriti rezultate, če želimo dvigati kakovost zdravstva. Na tak način bomo dosegli neko vzdržnost zdravstvenega sistema. Upam, da ne bomo vselej hlastali in jokali za tem, koliko denarja bomo potrebovali. Sicer pa menim, da moramo nekako sloneti na zgodovinskih danosti, analizirati to in to nadgrajevati, ker vsi tisti, ki zgodovino negirajo, bodo slej ko prej postali del zgodovine.
Gospa Zaletelj, danes praznujete 100. obletnico NIJZ. Kaj je prihodnost in kakšni so izzivi za vaše delo?
Ja, zdaj, glede prihodnosti zelo težko rečem, ker smo v fazi sprejemanja novega zakona o digitalizaciji, tako da to bi res težko rekla karkoli o prihodnosti NIJZ-ja, ampak to, kar jaz vidim pri samih podatkih, eno je kakovost podatkov, o tem smo že nekaj govorili in tukaj bomo morali tudi enkrat, zelo smo kritični do kakovosti podatkov, ki jo imamo, ker recimo, če nimamo preštete zdravnike, vse do čist zadnjega, je že vse narobe s podatki, ampak moramo vseeno vedeti, da tukaj gre za statistiko, tukaj ne gre za prav tist do zadnjega, ne vem, specializanta iz spodnjega dupleka, ampak gre za statistiko in enako je pri čakalnih dobah in tako naprej, tako da eden gor ali pa dol verjetno ne pomeni, ne spremeni kakšne big picture, in enako je recimo pri čakalnih dobah, a čaka 10.200 ljudi ali pa 10.400, vsi te čakajo predolgo, in na eno natančno to ni toliko zelo pomembno. Drugo dejstvo, kar se tiče podatkov, so te metodološke razlike, ki jih imamo. Vemo, da zelo velikokrat se je v zadnjih 2 letih slišali, da ne vemo v Sloveniji, koliko zdravnikov družinske medicine imamo. Seveda zelo dobro vemo, koliko jih imamo, ampak a nas zanima, koliko je timov, a nas zanima, koliko je zdravnikov družinske medicine, ki morda delajo tudi na NIJZ-ju, a nas zanima, koliko je aktivnih. Mislim, to so vsa različna vprašanja. Postaviti je treba prava vprašanja. In tretja dilema je pa tista, ki smo že prej omenili, povezana z drevesom in gozdom. Lahko na veliko sejemo te podatke, ampak treba je prepoznati gozd v njih in priti do pravih informacij iz njih. Hvala.
Hvala lepa, gospod Poldrugavac.
Hvala, jaz se bom navezal na to, kar je Dorjan prej povedal, in sicer o naših danosti. In sicer kulturno. Pri nas po merjenju organizacijske kulture zelo izstopamo po stopni kolektivizma napram individualizma. Sliši se zelo lepo, ker v bistvu pričakujemo, da bo skupnost skrbela za nas, ampak manj pozitivna plat tega je, da ne prevzamemo odgovornosti, ker jo predamo skupnosti na nek način. In se mi zdi, da tukaj pa, ker nekako moje strokovno ozadje udejstvovanja je področje kakovosti, ki je vedno pogled navznoter, se mi zdi pač ključno, da vsakdo izmed nas se sprašuje, kaj lahko v svojem malem, v svojem okolju, v sistem, kjer je dejaven, lahko naredi, da izboljša stanje oziroma ga pelje v smeri, v kateri želi. Konkretno pač, če je izvajalec lahko prispeva k boljši podatki, ki jih ima NIJZ, mislim, ni ključno toliko, da NIJZ najde tistega izvajalca, kakor da izvajalec se sam pri sebi sprašuje in seveda enako obratno mi na NIJZ-ju se sprašujemo, kako lahko izboljšamo pač komunikacijo in sodelovanje z temi izvajalci. Ampak ja, bi zelo poudaril ta element prevzemanja odgovornosti.
Doktor Ekanovič.
Hvala. Ja, jaz bi pa naredil majčken odklona. Nisem uspel nič ekstra govoriti o digitalizaciji, ampak glih ta beseda, nazadnje sem direktor, pa neko digitalno zdravje. Jaz bi pa zaključil s tem, da po vsem, kar smo danes slišali, mislim, da neka sinergija med posamezniki, pa orodji, ki jih imamo, ki jih bomo imeli, in mogoče manj samo te besede okrog digitalizacije. Jaz sam, podatke, analitika, pač to je okolje, v katerem jaz nekako živim, poleg tega, da seveda ja delam kot zdravnik. Ampak mogoče pomik k temu, to je tako kot vse druge oblike, lahko bi mu rekli evolucija. To je proces sprememb, ki se dogajajo s tehnologijo, ki nam je bila dana, razvita v tem času in mogoče, če bi se malo manj spopadali s tem, da v tem procesu smo in pač iz njega potegne najboljše, kar je, kar v prihodnosti nam zaradi tega bo omogočeno in dano, bi se mogoče tudi boljš počutili, pa bili manj odklonilni glede tega. Ker čisto recimo en tak karikiran pogled, vsak je verjetno kdaj gledal kakšno znanstveno fantastično film ali pa oddajo, ukvarjajo se s tem, kako letijo v medzvezdje, ne s tem, kako ladje delajo. In je zanimivo, ne? In vsi imajo nekaj od tega. Tako da to bi bila neka taka moja zaključna misel. Mislim, da nas čakajo dobre stvari po tej poti, po kateri gremo.
No in če smo začeli z gospod Tanjo, bomo tudi z njo končali.
Ja, mislim, ne vem, kje ne začnem, ampak to, da podatki smo verjetno mi, ne, in vse, kar je v podatkih, je o nas, kako jih bomo pač uporabili, tudi vemo, ne. Zdaj sem začeti jih moramo pametno uporabljati. Se bi pa tukaj zelo strinjala s tem, kar je Dorjan rekel, začeti bomo mogli spreminjati besede, kaj uporabljamo, ne, in komunikacija in kako komuniciramo je zelo pomembna. Na primeru raka dojk spet, ne, kje se ga operira, kjer kirurg je koliko operiral, kakšni so izidi. Jaz sem prepričana, da bi se vsaka pacientka, če bi imela te podatke, odločila za tistega kirurga, kirurginjo, kogarkoli, kjer ve, da bo najbolj kakovostno, pa ne najbližje k domu, ker zdaj se odločajo po temu, kar je najbližje domu, ker ne vedo tega. Če pa jih opolnomočimo, informiramo, izobrazimo, in to je ta komunikacija, ki se začne ne samo v šolah, na lokalnih ravneh, ne, da pač nehamo neke lokalne vrtičke ščititi in ne pošiljati ljudi v kompetentne inštitucije. In to je tisto, podatki so vedno lahko dobri ali pa slabi, samo kako jih bomo pač uporabili. In ne nazadnje moramo vedeti, da ti podatki so ljudje, da za njimi so osebe in ne samo tiste številke, ki jih pač tam gledamo, vrtimo ali pa kakorkoli predstavljamo.
Hvala lepa. Zdaj, Dorjan je vmes v diskusiji izpostavil, da je bil zelo vesel, da v dopoldanskem delu ni bilo veliko govora o številu bolnišnic, številu zdravstvenih domov. Jaz kot ekonomist moram reči, da sem pa zadovoljna, pa vas lahko to preseneti, da ko smo govorili o vzdržnih sistemih, pravzaprav nismo veliko govorili o fiskalni oziroma finančni vzdržnosti, ne. To je osnovni pogoj zagotovo, ampak tisto, o čemer smo se danes pogovarjali, so prave stvari. Pogovarjali smo se o tem, da rabimo graditi na kompetencah, da potrebujemo zadosti zavzetih, usposobljenih kadrov, ne samo zdravstvenih delavcev, tudi odločevalcev, da je strategija zdravstva po definiciji deležniška strategija, kar seveda pomeni, da potrebujemo sodelovanje, konstruktivno razpravo, ko iščemo rešitve, ker brez tega seveda ni tistega, kar je po moji oceni vzdržen zdravstveni sistem, to je prilagodljiv, fleksibilen zdravstveni sistem. In mislim, da je to naša največja frustracija v Sloveniji, da se pogovarjamo, da imamo količnike glavarinske stare 30 let, da prepočasi ažuriramo obračunske modele in tako dalje. Tako da tisti preboj, ki ga potrebujemo, je bolj prilagodljiv, bolj fleksibilen zdravstveni sistem, ki bo lahko naslovil potrebe pacientov in zdravstvene izide družbe kot celote, ker veliko učinkov bolezni seveda ne nastaja samo v zdravstvenem sistemu, ampak tudi v drugih segmentih naše družbe. Hvala lepa.
Kar ostanite, ste krasno ozadje, ker pred nami so samo še zaključne besede. Čas je zelo dragocena dobrina poleg zdravja, zato bodo tudi te tehtne in samo zaključne, tako sva se dogovorili, in jo vabim generalno sekretarko Mednarodnega foruma znanstveno-raziskovalnih farmacevtskih družb, magistrico Barbaro Stegel.
Najlepša hvala tem sjajnim idejam in sjajnim predavateljem. Danes vsebinsko seveda nimam kaj dodati, se pa lahko zahvalim. Tako da lepa hvala vsem govorcem danes na naši že 12. konferenci Vrednost inovacij, vsem sodelujočim v okrogli mizi in predvsem vam, ki ste nas obiskali osebno tukaj v Cankarjevem domu in seveda tudi vsem vam, ki nas spremljate prek spleta. In sicer hvala za vašo vztrajnost, ker nas že 12 let spremljate in bodrite in spodbujate pri našem prizadevanju za vzpostavljanje kar se da dobrega zdravstvenega sistema v Sloveniji in seveda za neko primerno mesto, ki naj bi ga inovacije znotraj tega sistema imele. S temi našimi konferencami se res vsakič znova trudimo prižgati neko iskrico zagona in vsakič znova tudi upamo, da bo prišla v verižno reakcijo in zanetla en plamen, s katerim bi lahko naš zdravstveni sistem postavljal en korak naprej, eno stopničko bliže boljšemu. Saj tako, kot pravi slovenski pregovor, kdor želi drugega vneti, mora sam goreti. In mi gorimo že 12. leto zapored. Brez vseh vas bi nam sigurno že zdavnaj zmanjkalo energije. In v kritičnih časih, ki jih delimo z drugimi evropskimi državami in tudi globalno, nas nazadnje premaga, če drugega ne, samo ohranitveni nagon, ker tako kot smo že večkrat rekli danes, vsi mi smo pacienti, še bomo pacienti in vsi menimo, da smo upravičeni do ustrezne, hitre, učinkovite zdravstvene oskrbe. In paradigma te oskrbe se spreminja z zvočno hitrostjo. Inovacije se vozijo s hitrim vlakom, umetna inteligenca v medicini, genske terapije. Vse to je že stvar današnjega, kaj šele jutrišnjega dne. To so zgolj orodja, mi pa se jih moramo naučiti uporabljati, kar se da strokovno, kar se da dobro. Vsi moramo izboljšati svojo pismenost, kar se tega tiče. In ta proces bo šel milom ili silom, bi rekli naši slovanski bratje. Ker zemlja pleše in plesati z njo ni zgolj težko. Je lahko tudi navdihujoče, imamo Rogliča, imamo Pogačarja. Seveda, če si upamo, če znamo in če vsi skupaj ugotovimo, ali gre za foxtrot ali gre za ča-ča-ča. In ni je prihodnosti, to smo tudi že danes slišali, brez in ni v prihodnost usmerjenega zdravstvenega sistema in tudi inovacij ni brez ene določene mere tveganja. Tvegamo že s tem, da smo, da živimo in živimo vsi zelo radi. Tako da to tveganje seveda si skušamo minimizirati, mi rečemo, da ga racionaliziramo, ampak na koncu moramo z njim živeti racionalno, ker brez njega tudi ni dodane vrednosti, ni življenja, ni razvoja. Vse naše konference pa so namenjene prav temu razvoju. Tako da naša zaveza in jaz upam, da tudi naša skupna obljuba ostaja, da ne bomo odnehali. Mislim, da tega tudi ne moremo in ne smemo. Tukaj pred vami stojimo, drugega ne moremo, je rekel Martin Luther že 500 let nazaj. In to velja za vsakega izmed nas, vsak izmed nas ima, tako kot je Mirša prejle poudaril, v tem procesu svojo osebno odgovornost. To nam narekuje tudi ta nuja prihodnosti, ki nas objema vedno tesneje in vedno bolj pritiska na nas. In kdo lahko narodu, ki je 1500 let preživel pod tujimi vladavinami s pomočjo lastne trme in neizčrpne spretnosti, kdo lahko temu narodu narekuje, kako naprej? Jaz mislim, da zgolj narod sam. To moramo opraviti mi sami. Naš skupni cilj, naša skupna vrednota po vseh meritvah je zdravje, zato zaključujem s pozivom, ki smo ga tudi že danes slišali, združimo moči in skupaj napravimo naslednji korak. Hvala lepa.
Hvala lepa. Moj zaključek bo čisto kratek in optimističen. Prihajam iz kraja, kjer smo dobili elektriko 2 meseca pred mojim rojstvom, pa se štejem za mlado. In takrat se je zdelo, kaj vse se z elektriko lahko zgodi, znanstvena fantastika. Jaz verjamem, da se za koga zdi znanstvena fantastika tematika, ki je bila danes tukaj obravnavana, ampak verjamem, da bomo na 22. konferenci govorili že drugače. Potrebujemo samo nekaj optimizma in akcije. Lep dan vam želim. Srečno.